via the aorta. So the aorta is a mediator to receive blood from the left ventricle and to pump the oxygenated blood to the systemic organs. While the pulmonary artery is used as a mediator to receive blood from the right ventricle, which is a blood rich in carbon dioxide, so blood that is poor in oxygen, the blood will go to the pulmonary artery to reach the lungs. And in the lungs, we will have a gas exchange, so the CO2 will go out and we'll have oxygen coming in. So we'll have at the exit of the lungs blood that is rich in oxygen. And this blood rich in oxygen will go back to the left heart via the pulmonary veins. So pulmonary veins will take blood from the lungs to the left heart, and the cycle will restart. So blood will go to the left ventricle, then to the aorta, then to the systemic organs. So in order for this to happen, for the cavity contraction to happen, we need to have electrical activity. So we need to generate electrical impulse in order to allow for the cavities to contract in order to pump blood to the different organs. And we'll see in this lecture how this is generated. So now we'll focus more on this electrical cycle. So we have the sinoatrial node, which is the most important pacemaker generator of electricity in the heart, which is located somewhere around the right atrium. So this SA node will generate electrical activity, and it will propagate to the right atrium and to the left atrium simultaneously. And then this electrical impulse will reach the AV node, which is a structure located somewhere between the atria and the ventricle. And this is another pacemaker cell. So when the SA nodes stop functioning, or we have SA node failure, the AV node will start producing electrical activity, but as the AV node is slower than the SA node, so it will give us a heart rate that is lower than the heart rate generated from the SA node. So when the impulse reaches the AV node, it will propagate to the ventricles via the bundle of His, which is located on the intraventricular septum. Then we'll have the bundle branches. We have the left bundle and we have the right bundle branch, which will propagate electrical activity to the left ventricle and to the right ventricle simultaneously at the same time. And then we'll have the Purkinje fibers, which are small fibers located between cardiac myocytes. So it will allow for propagation of electrical activity between cardiac myocytes. So as we said, the SA node is the fastest pacemaker node. It will generate electrical activity with a heart rate ranging from 60 to 100 beats per minute, which is the normal human heart rate in adults. And we have another pacemaker cell, which we call the atrioventricular node, or AV node, which will generate electrical activity in case of SA node failure, but a slower electrical activity, which we call a rescue electrical activity, between 40 to 60 beats per minute. The His bundle as well have the capacity to generate impulse, but here his rate is also slower, between 40 to 60 beats per minute. So the impulse that was generated from the SA node, as you can see here in this figure, will propagate in the atria via the intraatrial muscle bundles. So we have rapid atrial conduction because the right atrium is close to the SA node, but the electrical activity will also reach the left atrium very fast, simultaneously to the right atrium, because we have a connection fiber, which we call the Bachmann bundle. This Bachmann bundle allows for very fast electrical impulse propagation, so it will reach the left atrium simultaneously when it reaches the right atrium. So we'll have both atria that will contract at the same time, and both atria will pump blood at the same time in order to reach, for the blood to reach the right and left ventricle, and then to reach the systemic circulation and the lungs. So the process is physiological and is synchronous. So it occurs at the same time in both cavities. Another important point I want to focus on is that the right bundle branch, which we can see that goes to the right ventricle here, it's a single structure, while the left bundle the bundle that will go to the left ventricle is divided in two branches. We have the left anterior division and we have the left posterior division. So left anterior division is a thick fiber, so it's less likely to be affected by ischemia, while the left posterior division is a very thin fiber, so any ischemia or any blockage in blood flow will cause damage easier as compared to the left anterior division. So we need to know that we have left anterior division and left posterior division from the left bundle branch, but the right bundle branch is a single structure. So how this electrical impulse is generated from the SA node? So we said the SA node will generate this electrical impulse, but how this will happen? So mainly when you need to know that the action potential is responsible for generating this electrical activity, and the action potential refers to the traveling alteration in the electrical charge of an excitable cell membrane. So as you know, every cell contains a cell membrane, and this cell membrane contains negative or positive charges. And this is due to the passage of ions. So we have positive ions and like calcium and potassium, and we have other negative ions that will go in and go out of the cell via this cell membrane. So this passage of ions throughout the cell membrane will generate an electrical activity. And this is how the electrical activity in the heart is generated, by the passage of ions inside the cell and outside the cell, which will cause a modification of the cell membrane electrical charge, and this will generate electrical activity. So it's like the electrical generator that we have and the electricity that we generate outside the human body. It's nearly the same process here. So how can we explain this further? So we have four types of channels in the cell membrane. We have a channel called the funny current channel. We have the T-type calcium channel. We have the L-type calcium channel, and we have the outward potassium channel. So mainly it's a positive ions going inside and going outside of the cell, which will generate the action potential and electrical activity over time. So this is the action potential that you can see here on the graph. It's divided in three parts. So we're talking here about the action potential of the pacemaker cells, so the SA node and the AV node. The most important phase is the phase 0 of this action potential, because here the cell membrane will go from minus 40 millivolts to plus 20 millivolts, and this will generate depolarization and electrical impulse. And this is due to the opening of the voltage-gated calcium channels. So in the phase 0, the cell membrane will open its calcium channels, so calcium will go from outside the cell to inside the cell. So we have here passage of calcium channel from the outside to the inside. As opposed to phase 3, in phase 3, it's a phase that the membrane voltage will go from plus 20 to minus 60 millivolts, and this is where the potassium channel is open in the cell membrane, and this will allow for the potassium to go from inside the cell, from the intracellular space, to the extracellular space. So this is how we are generating our electrical activity in the cell. The phase 4, we said we have the third type of channels, which is called the funny channels, funny currents. This channel will allow for passage of sodium and potassium ions throughout the cell membrane. So it's affected also by the sympathetic nervous system, so by the norepinephrine, which is a neurotransmitter. So it's affected by the nervous system, and mainly it contains sodium and potassium channels. Phase 4 also contains another type of calcium channels, which we call the T-type, as opposed to the L-type that we saw in phase 0. And these channels will open somewhere when the cell voltage is around minus 50 millivolt. So it's a continuous cycle. It never reaches 0, so it never stops working 24/24. So it's always, we have a voltage in the cell membrane. We never reach 0, as you can see here on the graph. It's always above 0, even if it's negative, but we always have a charge and voltage circulating in the cell membrane. So it's a continuous and synchronous process. So I can't move the slides. I don't know what is the problem. I'm trying to fix it. Can you see the slides? Okay. Now it's changing. So I think you're seeing the new one, right? You're seeing it? Okay, great. So we'll continue. So how is this? We said that we have an action potential that is generated. How it's propagated between cells. So pacemaker cells will drive. We said will generate electricity and rhythmicity, which are the SA node, which is the fastest pacemaker cell, which will generate this activity, and this activity will be transmitted to the next. Uh, to the next next pacemaker cells and to their atria and to the ventricles simultaneously, as we said. So here is a summary of all what we said. We have the SA node, we have the AV node, we have the bundle of His, we have the bundle branches, and we have the Purkinje fibers. We'll start by going to details about the SA node, which is the most important pacemaker cells. The SA node is a banana-shaped structures, so it has a size that varies between 10 to 30 millimeters in length and 5 to 7 millimeter wide and 1 to 2 millimeter deep. So it's a three-dimensional structure located somewhere near the right atrium. So in order to for the sinus node to function and to generate activity, it needs blood supply for sure. So the blood supply to the SA node artery is originating from the right coronary artery. So we have in the human heart, we have the left coronary artery, which is divided in left circumflex artery and left anterior descending artery. And we have the right coronary artery. So the sinus node artery, which will give blood supply to the SA node, in order for the SA node to generate electrical activity, is coming from the right coronary artery. And this artery will run between the right atrium and the opening of the superior vena cava. So here is a coronary angiogram. You can see on the right side we have we have the right coronary artery, and you can see a lot of branches, and the sinus node artery branch coming from this right coronary artery is originating from the proximal part of the right coronary artery. So any ischemia or any blockage of blood in this artery will cause a lot of problems, will cause decrease in heart rate, will cause blockage in the electrical propagation. We'll see that later. So we said that the sinus node artery will originate from the right coronary artery, but it's just in 60% of individuals. And the rest of individuals, so the rest 39 or 40% of individuals, the sinus node artery will originate from the left circumflex coronary artery. So it's not just the right, sometimes it's from the left, depending on the dominance. And in rare cases, it can originate what we call from anomalous origin. So it's from the coronary sinus, from this descending aorta directly, or from the distal right coronary artery. Because we said from the 60% of individual, it originates from the proximal right coronary artery. It's just less than 1%. It originates in the distal right coronary artery. So in this distal region right here, but most often it's from the proximal region. So we said before, we're repeating it, we have the SA node, we have the Bachmann bundle, which is very important in order to propagate signal from the SA node to the AV node simultaneously, which will allow for both atria to conduct and to contract and to propagate electrical activity simultaneously. Next, we move to the second most important structure, which is the AV node, so the atrioventricular node. The AV node is serve as the connection between the atria and the ventricles, and it has a specialty to transmit the signal, the electrical signal, but with a delay. So we have here a delay of 0.1 seconds in the AV nodes. So this is what will allow to the completion of atrial contraction before the ventricles start to contract. So when the electrical activity reaches the AV node, we have a delay of 0.1 seconds. In these 0.1 seconds, the atria will finish its contraction, and then after this 0.1 second, the ventricle will contract. This is to prevent the atria and the ventricle to contract simultaneously, because in that case, the blood that is going from the atria to the ventricles will remain stagnant in the atrium. So we need this 0.1 seconds interval in order to allow for simultaneous contraction, and this is induced by the AV node. So it has multiple conduction pathway. We said we have the Bachmann bundle from the atria, between the atria, and we have the Wenckebach pathway, which is located inside the AV node. That we'll see it in another slide. So the AV node, we said we're repeating it as well. It's an electrical connection between the atria and the ventricle and the heart. It coordinates heartbeats, and it forms part of the heart electrical conduction system. It's a very important part. So its primary function is to transmit normal electrical impulse from the atria to the ventricle. But as compared to the SA node, it's a smaller structure. So this it measures 1 × 3 × 5 millimeters. So it's also a 3-dimensional structure, but here it's a lot smaller as compared to the main pacemaker cell of the heart, which is the SA node. So location, it's very important to locate it. We said why later, but the location of the AV node is it's located in the Koch triangle. It's a virtual structure, so there is no triangle, but we have landmarks for this triangle to locate it. So this triangle is bordered by the septal leaflet of the tricuspid valve, the coronary sinus, and the membranous part of the intraatrial septum. I will show you this triangle here. So you can see it's a hypothetical structure, so it doesn't exist in reality, but to have landmarks in order to that have the shape of a triangle. So we have the tricuspid valve annulus. You can see it here. So the tricuspid valve is a valve between the right atrium and the right ventricle, and it has it's 3 annulus. So we have the tricuspid valve annulus here. We have the coronary sinus here on number 3, and we have the tendon of Tadaro, which is located around his bundle, so in the septum. So we have these 3 landmarks, and the AV node is always located inside of these landmarks. Why it's important to locate the AV node? Because we have a lot of arrhythmias originating from the AV node, like atrioventricular AV nodal reentry tachycardia, which is an arrhythmia caused by like a loop of reentry starting inside the AV node. So we have a lot of techniques and procedures we call ablation, AV nodal ablation. So we can ablate this AV node, but in order to reach the AV node using multiple catheters, we need to know how to locate it. And to locate it, we need to locate this hypothetical triangle we said you can see here on the aerial image. So we have the septal leaflet of the tricuspid valve, we have the coronary sinus, and we have the tendon of Tadaro on the intraventricular septum, intraatrial septum. So the AV node is located inside of this triangle. And if you need to do procedures or to ablate the arrhythmia, you need to be able to locate this area. Another way to locate this area is by using fluoroscopy. So during ablation procedures, you can see here you have multiple catheters. We have a catheter in the right ventricle. We have a catheter in the coronary sinus. We have a catheter in the high right atrium. We have a catheter in the coronary sinus, as you said. So we need to locate this triangle. Fluoroscopy, we can locate it. Now we have new technologies like 3D mapping. We will not go in details, but you need to know that we have a lot of techniques to locate it without opening the heart. So we can locate it by doing imaging. So as we said, in order for the SA node to function, same, the AV node also needs to receive blood supply. And the majority of cases, in 80 to 90% of cases, the blood supply from the to the AV node is originating from the right coronary artery. So we said the SA node 60%. Here it's about 80 to 90%. The difference here is that the artery going to the AV node is not originating in the proximal right coronary artery. It's distal, so it's distally, not proximally, as we said for the SA node artery. The rest, 10% of cases are generating from the left circumflex artery. And we said it's depending on the dominance. So some individuals have right dominance and others have left dominance. So it depends on the dominance. You can see here, this is the another illustration. You can see the AV nodal artery, which is here on the distal RCA as compared to the sinus node artery, which is on the proximal right coronary artery. So it's just an anatomic variation to locate it when doing the procedure. How the AV node is developed? It's developed in the fetal life. So we have a lot of mediators like the bone morphogenetic proteins BMP, which are signals molecules. These molecules will allow for signals. These molecules they play a role in the development of the AV node, and they act through the mediator of another receptor, which is the ALK3 receptor, also activin receptor like kinase 3. And any aberration of the BMP and the ALK3 receptors will cause a lot of anomalies in the electrical conduction in adult life and in newborns. So they will have a lot of complications. You also need to know that the AV node contains two fibers. So it contains fast pathway fibers and contains slow pathway fibers. Usually, the fast pathway, normally in all individuals, the fast pathway will conduct electrical activity and the slow pathway will not conduct in normal cases. So the impulse that is originating in the atria will go to the ventricle via the AV node, via the fast pathway of the AV node. In some cases, especially when you have a premature beat originating in the atria and in individuals that are predisposed to have this pathology, the impulse will go to the slow pathway, and then we'll have like a cycle. Then it will go in a retrograde fashion to the fast pathway, and we have a generation of arrhythmia inside the AV node. We call this arrhythmia AV nodal re-entry tachycardia. It's not the topic of this lecture. We'll just focus here on anatomy. You will see it on other presentations. But you need just to know that the AV node contains two fibers, the fast fibers and the slow fibers. And normally the fast fibers are responsible of propagating impulse originating from the atria. So after leaving the AV node, the signals will spread through two main pathways. You have the bundle of His and you have the Purkinje fibers. So the bundle of His, they will give divisions and they will give the right and the left bundles. And the Purkinje fibers are the fibers that conduct signal at the speed of 1 to 4 meters per second. So they are very fast fibers. They can generate also electrical activity and heart rate between 30 to 40 beats per minute. So all of this process will allow for ventricular muscle depolarization, and this will allow for ventricular muscle contraction in order to pump blood from the ventricle to the systemic circulation. And you need to know that the endocardium and the papillary muscles of the valves and the septum will contract first. So they will contract first, and they will be followed by contraction of the apex. So the apex will contract last. This will allow for synchronous ventricular contraction. We said that we have blood supply in order to generate electrical activity, but also we need innervation. So we need blood and we need nerves. In that case, the innervation is mediated by the parasympathetic innervation and by the sympathetic innervation. So mainly the parasympathetic innervation is mediated by the vagus nerve. So it's a cranial nerve originating in the brainstem. It's cranial nerve number 10. This nerve is, we have the right vagus and we have the left vagus nerve. So the right vagus nerve will give innervation to the SA node, while the left vagus nerve will give innervations to the AV node. So it's not the same innervation, but both right and left vagus nerve will act via a neurotransmitter which was called the acetylcholine. Acetylcholine is an inhibitory neurotransmitter, so it will slow down heart rate. So it has a negative chronotropy, we said. So normally the SA node should generate heart rate between 90 to 120 beats, but when we have activation of this parasympathetic pathway, we have the heart rate that will drop to between 60 to 100. So we have a normal heart rate, meaning that this pathway is always activated in every human. So we always have it activated in order to have a heart rate between 60 to 100 beats per minute. The parasympathetic innervation does not influence ionotropy, so it does not have receptor in the ventricle, so the ventricular contraction is not affected. Just the heart rate is affected by the parasympathetic innervation. So we said left vagal, right vagal nerve, and acetylcholine. You just need to know these three things. While the sympathetic innervation, here the sympathetic innervation will allow for increase or decrease in ventricular contraction. So it has inotropic effect, not just chronotropic effect like the parasympathetic. And here we said that in the parasympathetic we have acetylcholine. Here we have the noradrenaline or norepinephrine, and we have the beta-1 receptors in the cardiac myocyte. So the same, it originates from the medulla or the midbrain area. So we have all the cardiac receptors in the midbrain area. They will give signals that will reach the heart via the norepinephrine and beta-1 receptors located in the heart. The beta-1 receptors will allow for increase in heart rate when stimulated and will allow to increase ventricular muscle contraction, as opposed to the parasympathetic, which will only allow for increase in heart rate. So here, increase in heart rate, increase in contractility. Moving now to the bundle of His. So the bundle of His is located in the interatrial septum near the AV node, just after the AV node. It contains bundle branches and specialized fibers to conduct electricity. It's closely connected to the AV node, as we said, which is crucial for coordination of heart function and propagation of electrical signal from the atria to the ventricle. So the His is a crucial bridge. We're repeating it, but it's very important, between the atria and the ventricle. Will facilitate rapid transmission of electrical impulses, allowing for the coordinated contraction of the heart chambers. So like the SA and the AV node, it needs blood supply, and mainly the blood supply here is from the right coronary artery, but it also can receive blood from the left system, like left anterior descending artery, but it's not a direct blood supply, so there is no branch going to the His bundle, but the LAD, left anterior descending artery, will give blood supply to this septal area. And we said that the His bundle is located in this area, so it will receive blood also from the surrounding tissue. So it's less sensitive to ischemia, because if we have a right coronary artery ischemia or stenosis or occlusion, it will continue to function because it will receive also blood supply from the surrounding area, and this is provided by the left anterior descending artery. So it's less sensitive to ischemia as compared to the AV node and to the SA node. So in case of poor blood supply, we can have conduction abnormalities, heart blockage, or arrhythmias. We'll discuss these things in different topics today during the day. And when it happens, we need to do immediate intervention and procedures in order to restore blood flow, in order to regain a normal heart rate or heart activity. So same saying here, we have innervations to the His bundle via the sympathetic and the parasympathetic. We said the sympathetic is mediated by, is originating from in the midbrain, in the brain, in the midbrain area. Then it will give norepinephrine and will reach the heart via the beta-1 receptors in the heart. It will increase contractility and it will increase the heart rate. It also has parasympathetic innervation via the right and the left vagus nerve, and here it's mediated by acetylcholine. And the role of this neuromediator is to slow down the conduction and slow down the heart rate. So it has a negative chronotropy. It doesn't have an inotropic effect. It doesn't affect the contractility. Now moving to the next structure, which is the bundle branch. So we said we have the right bundle branch and we have the left bundle branch. We said that the right bundle branch is a single structure. It will propagate electrical impulse to the right ventricle, while the left ventricle is a dual structure. It contains left anterior branches and left posterior branches. And we said that the left anterior is a sick structure, while the left posterior is a thin structure. And these structures will allow for electrical impulse to propagate from the His fibers to the ventricles, and it allows simultaneous propagation to the right and to the left ventricle. So both ventricles will contract at the same time, 0.1 second later than the atrial contraction. So the function of the bundle branches, so we said it play a critical role in transmitting electrical impulse from the AV node to the ventricles, ensuring coordinated contraction of the ventricles. So so we have the right bundle. We said it conducts impulse. I'm repeating it because very important. It conducts impulse to the right ventricle and the left bundle, which will allow for conduction of impulse to the left ventricle, and it's divided in left anterior and left posterior fascicles. So they will penetrate the myocardium, which is the heart muscle, and they will transmit the electrical signals there. And this will allow for transmission of impulse throughout the ventricles simultaneously. So it's very important, simultaneous transmission of impulses. Same thing, the nerve supply is innervated by sympathetic and parasympathetic. We'll not repeat it. It's the same as other structures in the heart. It's identical. So what can go wrong here? Sometimes we have something we call bundle branch block. So we have right bundle branch block, we have left bundle branch block. We'll see how the ECG is affected. So the right bundle branch block is the impaired conduction in the right bundle branch, and left bundle branch block is impaired conduction in the left bundle branch block. It's very easy to diagnose it. You just need to do an ECG. The ECG will show characteristic signs. I will show you this on next slides. We will have widening of the QRS, and we'll have characteristic signs on the ECG for easy diagnosis of this pathology. So when we have a right bundle branch block, you can see here as the right bundle is blocked. This is most commonly due to ischemia, so less blood supply reaching the bundle branches. So we'll have here depolarization of the left ventricle before the right ventricle because we have a blockage in the right ventricle. So the electrical activity will go to the left ventricle, and from the left ventricle, it will go again to the right ventricle. So we have a delay, and this delay will cause a widening of the QRS complex. So on the left, you can see the normal ECG, the QRS complex. This is narrow, while when we have a right bundle branch block, the QRS become larger, and you will have this shape RSR prime, which is called also M shape. So when the QRS becomes wider, it indicates that the left ventricle and right ventricle are not contracting simultaneously, and we have a blockage either on the right, in the right branch or in the left branch. So both right bundle branch block and left bundle branch block will cause widening of the QRS. But in order to differentiate between them on the ECG, you just look at the shape. So the right bundle will give a RSR prime shape or the M shape, while the left bundle will give you the negative deflection, which is the RS, which is mainly predominant negative wave in lead V1, while in the right bundle, we look at lead V1, it's predominantly positive. So it's easy. Always look for widening of the QRS as compared to a previous ECG where it was normal in size. And if it's predominantly positive in V1, it's right bundle branch block, and it's predominantly negative in V1, so it's most probably a left bundle branch block. So it's very easy to diagnose it. You just need to do an electrocardiogram. So the treatment of when you have bundle branch block, it depends on the cause. So when we have an ischemia or a myocardial infarction causing this, we need to open the vessel in order to regenerate blood supply to this area, so to decrease the blockage. Moving now to the last part of this electrical activity, which is the Purkinje fibers. So the Purkinje fibers are specialized cardiac muscle fibers located within the myocardium. So here we start talking about cell-to-cell electrical transmission. So between myocardial cells, they spread throughout the ventricles, so they are highly effective for transmitting electrical signals. They are this type of fiber is very widely present in the ventricle, so it's present between all cells. They serve as a final stage of cardiac conduction system, and they are responsible for rapid conduction of electrical impulse from the bundle branches to the ventricular muscle cells. So they will ensure a synchronous contraction of the ventricles. So both ventricles will contract at the same time because of this. Like other structures, we have the sympathetic and the parasympathetic innervation as well that are present at this level also. Here, you need to know for the blood supply, the RCA, right coronary artery, will give blood supply to the Purkinje fiber located in the right ventricle, while the LAD, left anterior descending artery, will give blood supply to the Purkinje fibers located in the left ventricles, while the left circumflex artery will give blood supply to the lateral and posterior walls of the ventricle. So we can say that we have blood supply coming from all arteries. So it's not affected directly by ischemia because it has blood supply originating from 3 main arteries. So it's safer as compared to the SA node and to the AV node. So we'll talk briefly here about what can go wrong in this system. What are the pathologies that can result from any alteration in the electrical conduction? So we'll talk briefly about these pathologies because you will see them in the next topics of today. So we'll talk about them in details. But I will just talk briefly about all the pathologies that can result from the alteration in the electrical transmission. So we said we can have the bundle branch block. So we have the right bundle branch block and the left bundle branch block. Depends if the blockage occurs on the right bundle or on the left bundle. And when the blockage occurs, we will lose this simultaneous contraction of the ventricles, and we will have one ventricle that is contracting before the other ventricle. And we said that on the surface ECG that we do, we will detect it by widening of the QRS. So any widening of the QRS indicates two ventricles are not contracting simultaneously. So the QRS, you see a previous ECG, you compare also always to a previous ECG, you see that the QRS is narrow. A narrow QRS is a QRS between 80 to 120 milliseconds, while a wider QRS is above 120 milliseconds. You can measure the width of the QRS on the ECG paper. So we said in both right bundle and left bundle, we'll have widening of the QRS complex. But to differentiate between the two, in the right bundle, you have the predominant positive waves in V1, or we call it the M-shaped wave, or R prime wave, while in the left bundle branch block, it's predominantly negative. So white QRS was a predominantly negative wave in V1, it's a left bundle branch block, and white QRS was a predominantly positive wave in V1, it's a right bundle branch block. So always when you have a widening of the QRS, you need to look at lead V1, because lead V1 is the most important lead in order to differentiate between right bundle branch block and left bundle branch block. So it's easy to diagnose it. You just need to do an electrocardiogram. It's a non-invasive diagnostic tool. So the treatment, it will depend on the underlying cause. It's whether it's ischemia or another cause, but the main most important thing you have to do when you see a bundle branch block is to look on the previous ECG. If the bundle branch block is old, it's reassuring. So we know it's not an acute ischemia that caused it. But when you have a new onset bundle branch block, in addition to chest pain, for example, in the patient presenting with a new onset bundle branch block and chest pain, here we need to suspect acute coronary syndrome and acute ischemia. So in that case, we need to do urgent interventions and urgent revascularization. I will show you here an example of a patient. Do you think here the QRS is narrow or it's wide? Can you tell me in the chat, please? How can you describe this QRS? It's narrow or it's a wide QRS? Okay, so the QRS is this. Okay, so yeah, it's normal. As you said, it's narrow QRS, true. So correct answers. Here it's a narrow QRS. So this is his baseline ECG for this patient. Few months later, the patient presented to the emergency department with chest pain. So how can you describe this QRS here? It's a wide or it's a narrow QRS? And what type of bundle branch block do we have? Yes, it's wider. It's clear it's wider. And what type of bundle branch we have here? It's a right or a left bundle? Yes. So yes, you're giving correct answer. It's a left bundle because we said when we have a widening of the QRS, we always have to look at lead V1. And when lead V1 is predominantly negative, so we need to suspect a left bundle branch block. So what to do next for this patient? Can anyone tell me? What do you think we should do for this patient? What is the next best step to do? Yes, we need to, we can ask for troponin for sure. We need to do labs and do troponin, check previous ECG. Yes, we checked the previous ECG, we show it wasn't present, so it's alarming for us. So the troponin, let's say the troponin came back very elevated. So what to do next in that case? Yes, exactly, Razan. We need to do PCI. So we need to do an urgent coronary angiogram in order to check if we have a blockage involving an artery. So this is what we did. We sent the patient emergently to the cath lab, and we visualized that the patient have a total occlusion of his proximal left anterior descending artery responsible for the bundle branch block, and we put a stent and the wire first. We were able to cross this occlusion, and we then put a stent. We put a stent, and we had a restoration of blood flow, and so it was a case of myocardial infarction causing bundle branch block. The message here is always when you see a bundle branch block to just look at the previous ECG. If the bundle branch block that wasn't present on the previous ECG, and if the patient have symptoms, chest pain or typical symptoms, you need to do troponin for sure and to do the labs, but you need to send the patient directly to the cath lab and consider it as acute coronary syndrome or STEMI, so ST elevation myocardial infarction equivalent. So another pathology that can result from alteration of the electrical conduction is AV block. We'll just go briefly about this now because you will have another lectures about AV block today. I will show you a small video about it. Can you see the video and hear the sound?
Pumps blood around your entire body, coordinated by an incredible electrical system. Normal heartbeats begin when your SA node fires an electrical impulse. This makes your atria contract, forcing blood into your ventricles. When the impulse reaches your AV node, it pauses before moving through your ventricles. This makes your ventricles contract, forcing blood out of your heart and around your body. If you have complete heart block, your AV node doesn't pass these impulses to your ventricles. A backup system will take over and keep your ventricles contracting. They will contract at a much slower rate. This means your heart will beat too slowly, affecting the flow of oxygenated blood to your body and brain. Find out more about heart block and our pump.
So this is mainly how it happens. So we have three types of, we'll just go briefly as we said, we just have three types. We have the first degree heart block. The first degree heart block is when the electrical impulse move slower inside the AV node. So here it's a benign pathology. It's present in a lot of people and they are asymptomatic. So when we see first degree heart block, we don't do anything. We just need to check the medications because some medications can cause it. And also here the diagnosis is based on the ECG. So you will see on next lectures how to diagnose it on the ECG, prolongation of the PR interval. We'll not go into details now. But mainly you need to know that it's a benign pathology and it can be caused by medications, mainly heart rate lowering medications like beta blockers. So any medication that can slow the heart rate can cause it. Calcium channel blockers and digitalis or digoxin. So you just need to know these three things for now. Second degree heart block is a heart block that can start to cause symptoms. Here we said first degree heart block is an asymptomatic pathology, but second degree heart block here, the patient can start to report symptoms, and it's a wider variety of symptoms going from chest pain to dizziness to syncope. So the symptoms are not very specific, but it can mainly cause syncope, which is the most common presentation for a patient with second degree heart block. And it's divided in two types, also based on the electrocardiogram. You will learn how to differentiate between the two, the Mobitz type 1 and the Mobitz type 2. Both are second degree heart block. The Mobitz type 1 is a benign condition, mainly mediated by vagal nerve stimulation. It occurs in athletes and young individuals, mainly during sleep. We detect it by telemetry or by Holter monitoring, but we don't do anything for it. We just need to check the medication as well. The Mobitz type 2, which is a high degree heart block. Here it can cause severe symptoms, it can cause syncope, it can cause cardiac death. So in that case, it's usually due to ischemic events, so decrease in blood flow. So when it occurs, we need to send the patient and put a pacemaker. So here it's an indication to put a pacemaker. So third degree heart block is also a very life-threatening and severe condition. It's the highest degree of heart block. It occurs below the AV node. So we call it infrahisian block. So it's sometimes at the exit of the AV node or below. So when the blockage is below, we call it a third-degree heart block. Here also it can be due to a lot of conditions like medications, as you said, beta blocker, or intoxication of beta blockers, digoxin and calcium channel blockers. The most important and the most common cause of it is myocardial infarction. So we have decreased blood flow to the electrical system, a heart attack, so myocardial infarction, post-heart surgery, because after heart surgery we have edema, myocardial edema. So we'll have edema in this area, and this will cause a blockage in the system. We'll have some infection like Lyme disease. It's a disease mainly present in the United States. We don't have it in our areas. I think we don't have it here. This disease is mediated by a vector, so it's a tick bite. So it's like an insect bite. It will cause circulation of autoimmune and of antibodies inside the blood. They will go to deposit on the electrical system, and they will cause damage. So any cause, any condition causing third-degree heart block, especially if irreversible, here we need also to put a pacemaker in order to treat this condition. So we will develop it in another session in details. I will just go also briefly for the next few minutes about another electrical problem, which is the long QT syndrome. I'm sure you hear about it. It's a cardiac disorder affecting the electrical system as well, and it can lead to irregular, it can lead to life-threatening arrhythmias. So you see in the first image from the Cleveland Clinic, you see a normal QT interval here. On the second one, you see a prolongation of the QT interval. So this is what we call a long QT, and you can see that all of these pathologies can be diagnosed very easily on the electrocardiogram. So you don't need to do any invasive procedure, or the diagnosis is based on the electrocardiogram. So we have a delay in ventricular action. So long QT syndrome results in extended time for the lower chamber of the heart to contract and relax. And prolonged QT intervals can be occasionally caused by routine events. So a lot of patients have this long QT on their ECG, but it doesn't manifest. Sometimes it needs a trigger to manifest. So sometimes sudden noises or explosions, for example, can induce it. Heavy physical exercise or activity or intense emotional experiences can also trigger it. So if you have it, or if we have it genetically, we need sometimes trigger. Even if we have it, we need trigger in order for it to manifest and cause pathologies or cause arrhythmias or cause sudden death. So we have 17 types of, these syndromes can be congenital or can be acquired. For the congenital part, we have 17 types, but the most important types and the most common types are long QT syndrome 1, long QT syndrome 2, and long QT syndrome 3. And these syndromes, the QT1 and QT2, are caused by decreased function of the potassium channels. That we said, you have potassium channels on the cell membrane. We have decreased function of these potassium channels. And QT syndrome 1 is mainly triggered by exercise, while QT syndrome 2 is mainly triggered by emotional stress. So a breakup or any emotional stress can induce it. While long QT syndrome type 3 is caused by increased function in the sodium channels that are present on the cell membrane. And these are mainly triggered during sleep. So sometimes you hear about someone that passed away when he was sleeping. It can be, especially if a young patient, it can be caused by long QT syndrome type 3, or another cause that can cause it is left ventricular hypertrophy. But you need to know here that it's triggered by sleeping. So the symptoms can range from fainting, so syncope, abnormal heart rate, or abnormal rhythms, or tachycardia. It can cause tachycardias. You need to know that the most life-threatening tachycardia that can be caused by long QT syndrome is torsade de pointe, or it's a polymorphic ventricular tachycardia. It's a very dangerous tachycardia. Here, when you see it, you need to give intravenous magnesium sulfate. And if it doesn't respond, you need to give a cardioversion, so a synchronized cardioversion or a electrical shock in order to reverse it. And if it doesn't respond to all of these things, you need to do something called tachycardia pacing. So we need to put a pacemaker and start pacing faster than this tachycardia in order to stop it. Another conditions that can cause it are medication. So it can be medication induced. It's the most common cause of long QT on the ECG, and we have a lot of medications, mainly antibiotics. So we need to be careful when we prescribe such antibiotics. If a patient is at high risk, we need to do an ECG before prescribing these antibiotics like levofloxacin, ciprofloxacin, used for pneumonia or for UTI. It's very commonly used. Another types of medications are antidepressants and antipsychotics. So the medications are widely used nowadays for a lot of patients, so we need to be careful. We have also antiarrhythmics like amiodarone. You know that amiodarone is given to treat arrhythmias, but it's a pro-arrhythmic medication. So sometimes it can induce a prolongation of the QT segment, which will induce arrhythmia as a side effect. So we call it a pro-arrhythmic. So it treats arrhythmias, but it's also a pro-arrhythmic drug. It can cause a long QT and cause polymorphic ventricular tachycardia. And the others, sotalol, quinidine, flukinamide, dofetilide, and albutilide, all are also sodium channel blockers and potassium channel blockers that can induce it. So other causes are electrolytes. So hypokalemia, hypomagnesemia, and hypocalcemia can also cause prolongation of the QT segment. Another also rare condition, which is intracranial hemorrhage or intracranial increase in intracranial pressure. You can see that you have blood here in the brain. So as a result of this intracranial pressure, you can detect it on the electrocardiogram by widening of the QT segment. So you always need to think about it when you see this on the ECG, especially when the T wave become inverted and the ST segment become wider, the QT segment become wider. You need to think of intracranial bleeding or high intracranial pressure. So the diagnosis is very easy. It's on the ECG. You need to take the history from the patient. You need to do an ECG, and then we need to stratify the risk based on each patient. So if the patient has cardiac arrest, is a different patient that doesn't have any symptoms as a result. The age is also a factor, the sex and the genotype. And depending on all this risk stratification and on the ECG, we can put the patient on treatment. Usually we put him on beta blockers in order to prevent the arrhythmias. And if it doesn't work, or if he had a cardiac arrest, you need to put a defibrillator, and you need to implement a defibrillator on an ICD in order to prevent the sudden cardiac death as a result. And that was it for my first presentation. If you have any questions, please let me know in the chat. Thank you. Any questions? Okay, I have a question about left bundle. So the left bundle, we have the left anterior fascicle and the left posterior fascicle. So we have two fascicles as compared to the right bundle, which have only one fascicle going to the right ventricle. Okay, great. So our next lecture for today is about the ECG basics, so electrocardiogram basics. We'll start. You just need to know that in order to perform an ECG, you need 10 electrodes. So these electrodes, you have to place them on the left arm, right arm, lower limb, and left lower limb and right lower limb. And you need also to place the right arm, left limb, and right limb, lower limb, are called the limb leads. You have also the pre-chorded leads, which you place them on the anterior chest, which are V1, V2, V3, V4, V5, V6. So I will show you how to place them. So we need 10 electrodes in total in order to generate a 12-lead ECG. So you always need to know the anatomy, because any lead misplacement can cause misdiagnosis on the ECG. So you always need to locate the manubrium and the sternal angle, and then you need to count the intercostal spaces. So you need to put the V1 and V2 on the third intercostal, fourth intercostal space, and then you have V4, V5, V6 that are located one intercostal space under it. I will show you another one, another image. So you can see here V1 and V2, and then V3 you put it in the middle between V2 and V4, and then V4 in the fifth intercostal space, V5, V6. V6 is the most lateral or one. So we said we have, in order to generate a 12-lead ECG, you need 10 electrodes, 4 limb leads, which are right arm, left arm, left lower limb, and right lower limb. And you need V1, we need also the pre-chorded leads from V1 to V6. So we need 10 electrodes. So here is a representation of the limb leads, right arm, left lower, right lower. So you just need to place them accurately. Sometimes we can be asked to do a right-sided ECG. So when we do a right-sided ECG is when we're suspecting right ventricular infarction or right ventricular pathologies. So instead of putting the precordial leads on the left chest, we put them now on the right chest, and we call them V1R, V2R, V3R, V4R, V5R, and V6R. So sometimes we can do both simultaneously. We put the left precordial leads, V1 to V6, and we just can put one right-sided lead, which is V4R. So here we can have an idea what is going on also on the right sided of the heart, not just the left side of the heart. It's better to do this always, especially when a patient comes with suspected symptoms or with typical chest pain. Sometimes also we can do posterior leads. So we put V9, V8, V7 on the back of the patient posteriorly. So V7 is placed posterior in the posterior axillary line. So at the same level of V6, but posteriorly, V8 next to it, and V9 in the left paraspinal region. So, but we should be on the same level as V6 in the anterior chest. So we do this to locate any posterior myocardial infarction, so involving the posterior ventricular wall. So it's very important to always suspect it and do it, not just do the anterior leads. We need sometimes to do the right leads, and we need to do the posterior leads. So we need to do everything sometimes. It's very important. To understand how an ECG wave is being generated. So when we put all these electrodes, we'll have a generation of an ECG complex. In this ECG complex, you have the P wave. So P wave is depolarization of the atrium. So when the atria contracts and depolarizes, you will have a generation of a PR interval. So the atria will contract and the electrical activity will propagate to the AV node. So this will generate a PR interval on the surface ECG. The QRS complex, as opposed to the PR interval, the QRS complex is the ventricular depolarization. So when the ventricular depolarizes and contracts, you will detect it on the ECG as a QRS complex, so QRS. And then we have the ST segment and the T wave. So here we're now in the repolarization or ventricular relaxation. So all of the ventricular function can be detected on the surface ECG. So the atrial depolarization, ventricular depolarization, and ventricular relaxation are represented on the ECG. It's very important also to understand how the ECG is being generated. So on any ECG paper, you can see small squares and big squares. So each small square is 1 millimeter in width, and it's 40 milliseconds in time, or 0.04 seconds. While a big square, which is composed of 5 small squares, here it's 200 milliseconds or 0.2 seconds. So a small square is 40 milliseconds, and a big square, meaning 5 small squares, are 200 milliseconds. So it's very important here. And the width is 1 millimeter. So you always need to also look at the paper speed at which the ECG is being recorded. It should be 25 millimeter per second in order to have a normal ECG tracing. You need to have a 25 millimeter per second. You always need to be careful of this, because sometimes the machine will give you another number. So we need to fix it and do a speed of 25 millimeter per second. So in order to calculate the heart rate, we can calculate the heart rate on the surface of ECG. You should understand that when we have a paper speed of 25 millimeter per second, so the rhythm strip comprises of 250 small squares. So each 10 seconds is 50 large squares. So in order to calculate the heart rate, you should know that the heart rate is calculated for how many beats per minute. So 1 minute on the ECG is 300 large squares, or 1,500 small squares. So in order to calculate the heart rate, as you can see here, the first method is the large square method. We need to divide the 300 number, because we said that 1 minute is 300 large squares. So you need to divide 300 by number of large squares. So for example, if we have one large square between two QRS complexes, so it's 300 divided by 1. So here it's a 300 beats per minute. It's a very fast heart rate. So it's a very dangerous condition for sure. When you have two big boxes, so the heart rate here is 300 divided by 2 is 150. When you have 3 big boxes, so 1, 2, 3 here, it's 300 divided by 3 is 100 beats per minute. While here we have 4 big boxes, so it's 300 divided by 4 is 75 beats per minute, and the last one is 300 divided by 5 is 60 beats per minute here. We have another method which is a more accurate method. So here it's a method that involves using the small squares, because sometimes it's better, it's more precise to measure the small squares. We said that 1 minute is 300 large square or 1,500 small squares. So it's the same. We calculate the number of small squares between two QRS complexes. So here, for example, it's 1,500 divided by 5 small squares, which give us 300 beats per minute. Here as well, we have 15 small squares, so it's 100 beats per minute, because it's 1,500 divided by 15. So here it's 3 big boxes or 15 small boxes. So either you use the big box method or the small square method, you will have the same result. But the small square method is more accurate. So I personally use it more than the big boxes method in order to calculate the heart rate. You need to know that the normal heart rate in adults is between 50 to 100. Sometimes we say, depend on the reference, 60 to 100, but usually we can consider 50 to 100 is the normal heart rate. Tachycardia is about 100 and bradycardia is less than 50. While in pediatrics, it's different here. Newborns usually have faster heart rates, so a heart rate of 150 in a newborn is normal. And as we grow up by age, the heart rate, the resting heart rate will start to drop in order to reach the adult heart rate at 6 years and plus. So you can see on the first image, it's a normal sinus rhythm. So normal sinus rhythm is the normal heart rate, normal heart rhythm that we should all have. We have a P wave, so it's a P wave followed by QRS complex, followed by a T wave that is repeating from cycle to cycle, and it's regular. This is the definition of a sinus rhythm. So it's a rhythm originating from the SA node and propagating throughout the arts. So we have P wave followed by QRS, followed by T, and the RR interval. So the interval from QRS to QRS is the same from this QRS to this QRS. So is the same interval, and the heart rate is between 50 to 100 beats per minute. While in cases of sinus tachycardia, as you can see here, you also, when we say sinus, so sinus is always we have P wave and we have a regular rhythm. But to differentiate between these three conditions is here we have the heart rate. So these three conditions, sinus rhythm, sinus tachycardia, sinus bradycardia, all of these conditions have P waves, have QRS, has T waves, and are regular rhythms. So it's regular and with a P wave to say sinus. The difference is the heart rate. So in the first one, you have a normal heart rate. The second one, you have a very fast heart rate. And the third one, in case of a sinus bradycardia, the heart rate here is a lot slower. So we just need to measure the heart rate in order to diagnose it. But the most important part here, when you look at sinus rhythms, is to look for P waves and to look for regular rhythms, depending on the heart rate. But you need to be able to identify P wave and to identify that if it's a regular rhythm or if it's an irregular rhythm. The second step, so as we said, you need to know if it's irregular or it's an irregular. So it's irregular rhythm, the duration between RR segment is the same duration between the next RR interval, and the same within the third one. While when it's irregular, when you measure the RR interval in seconds, you will see that the first RR interval is different than the second RR interval. Usually we see this irregularity in cases of atrial fibrillation. We'll see it on next slides. So the third most important step is to be able to identify the P wave, because we said that presence of P wave and regular rhythm mean it's a sinus rhythm, while absent of P waves and or irregular rhythms, it means it's not a sinus rhythm. So on the first one, you can see P waves clearly, P waves followed by QRS, followed by T, P followed by QRS, followed by T. While in the second one, there's a lot of artifacts. We can't locate a clear P waves. We need to have the same P wave that is before each QRS segment, and it's a bit irregular on the second one. So most probably the second one is an atrial fibrillation tracing. So it's not a sinus rhythm. Moving on, so after we calculated the heart rate, we checked if it's a sinus rhythm or not, if we have P waves, if it's regular, we need to look at the QRS morphology. So I showed you here all the QRS morphologies that you can have. So if the QRS is just a positive wave, you call it just R wave. You don't say QRS, you call R wave here. When we have a positive wave followed by a negative one, so we have an RS complex, as you see on the second one. Sometimes you can see the presence of a Q wave, like here. So we have a Q wave, it's a first negative wave followed by R, so we call this complex a QR complex. So we'll not go a lot in the details, but you need to know that you can have a lot of shapes of the QRS complex, and you can sometimes have a Q wave. Q wave is very important because when you see a Q wave, you need to suspect an ischemia. We'll talk about ischemia also in this lecture, but a bit later on. So now it's very important to know the QRS morphology. Either it's a narrow QRS or it's a broad QRS. If you remember in the first presentation when we talked about bundle branch blocks, we said that bundle branch blocks is a QRS that is wider. Here we'll focus more on the duration of the QRS. So when the QRS is less than 100 milliseconds, or less than 120 milliseconds, so less than 3 small squares, because we said that each small square, so I don't know if you're seeing my pointer, so this one is 40 milliseconds. So here we have 1 and 2 small squares, so the duration of the QRS here is 80 milliseconds. The second one, when we have a widening of the QRS, we can see that we have 3 small squares. So here the QRS is 120 milliseconds, so the QRS is wider. When we have a narrow QRS, so we know that the impulse is originating in the supraventricular area, so above the ventricles. When we see a wider QRS, so we know that the impulse is originating in the ventricular myocytes. So it's very important to differentiate between the two, and we need to know that the normal QRS width is between 70 to 110 milliseconds. When it becomes above 110 or above 120, here we start to talk about widening of the QRS segment. Here is an example of an ECG that shows this is a normal complex, so P followed by QRS followed by T. Then we have a premature complex. This, if you measure this QRS, it's 3 small squares, so it's a wide QRS. So in that case, we call it a ventricular ectopic beat. So it's a premature beat. You can see that it comes earlier than expected, so it's a ventricular beat. And you can see that this pattern is repeating itself. So normal beat followed by PVC, normal beat followed by wide beat, normal beat followed by wide beat, normal beat followed by wide beat. When we see this, we call it a ventricular bigeminy. So a normal beat followed by a premature beat, and it's keeping to repeat itself. So we call it a ventricular bigeminy. So when the QRS is wider, we need to diagnose ventricular ectopic beats. So we'll now focus a bit on narrow complex rhythms. So when we have the narrow complex, so the QRS is between 80 to 110 milliseconds. So in that case, the rhythm is originating in the above the ventricle, so in the supraventricular area. So here the sinus rhythm is a P wave followed by QRS followed by T, and it's a regular rhythm, as we said, as opposed to atrial fibrillation, which is also a narrow complex rhythm. But what the difference here is what? Can someone tell me what is the difference between the atrial fibrillation and the sinus rhythm? What is the main difference between both? So between the second tracing and between the first tracing, what is the main difference? Okay, yes, no P wave. What else? As Ali said, he said no P wave, so we can't detect a P wave, a clear P wave in the second rhythm. The other difference is it's also irregular. Yes, true. It's irregular and no P waves. So here is a narrow complex, but it's irregular without P waves. So it's not a sinus rhythm. It's originating in the supraventricular area above the ventricle, but here it's atrial fibrillation because it's irregular and without P waves. So now sometimes we can have wide complex rhythms. So as we said in the first lecture, it's bundle branch blocks. So the QRS will become wider, and when we always look at lead V1, if it's a positive deflection with an M shape, it's a right bundle branch block, or if it's a negative V1 deflection, it's a left bundle branch block. Other causes can cause widening of the QRS complex is the hyperkalemia, so electrolytes, or medication intoxication like tricyclic antidepressants, or other pathologies like Wolff-Parkinson-White syndrome, ventricular pacing, and hypothermia. All of these conditions can induce widening of the QRS complex, so the QRS complex will become above 120 milliseconds. Can someone tell me what is this rhythm that we're seeing here? First describe it. Is it narrow or a wide QRS here? And is it tachycardic, bradycardic? What is this condition? Can someone tell me? Yes, as Nadia and Ahlam said, it's a wide complex ventricular tachycardia. Exactly. So here the QRS complex is above 120 milliseconds. So it's wide, 3 small squares, and it's very fast. The heart rate here is it's around it's around 200 beats per minute. So it's a ventricular tachycardia. And how to treat this? If the patient is unstable, what should we do now? If the patient is the patient presents with this and is unstable, how to proceed? Okay, yes, true. Ahlam, we need to shock him. So we need to administer a defibrillation or a shock in order to treat. True. So I got correct answers. Now it's very important also to look well on the ECG, because the ECG can give you a lot of diagnosis and a lot of diagnostic tools. You can detect left ventricular hypertrophy. So left ventricular hypertrophy is a thickening of the ventricular myocardium. So when we have left ventricular hypertrophy, you can detect it sometimes on the ECG. We have a tool which we call it the Sokolow-Lyon criteria. Sorry. This tool is the Sokolow-Lyon criteria. You need to look at lead V1 and measure the QRS complex in millimeters. We said that each small square is 1 millimeter. So here V1 is 16 millimeter. And then you look at lead V5 or V6. You take one of them. Usually we take the longer. So here V6 is around 32 millimeters. And if we add 32 to 16, we will have 48 millimeter, which is above 35. So when V1 plus V6 is above 35 millimeters, so here we need to suspect left ventricular hypertrophy. So always when you look on the ECG and you see very tall waves like you see here, these are very tall waves, you always need to calculate V1, the S wave in V1 plus the R wave in lead V6 or V5. And if you get a number of above 35 millimeter, you need to suspect left ventricular hypertrophy. In that case, you need to order an echo in order to measure the left ventricular septum, because left ventricular hypertrophy can occur in young individuals and is also a risky condition and can lead to sudden cardiac death. So the ECG is very essential and it's very easy tool to diagnose it. Sometimes can someone tell me here what is when you look at this ECG, what do you think? There's something that directly comes to your mind when you look on this ECG. Can someone tell me what is the main problem here? Just by looking at it, what do you see? No, AFAF is saying it's a flat ECG. It's not flat here, because you can see that you have waves. So when the flat ECG is like this, so there's no wave at all. Yes, exactly. So Ali is saying low voltage. Ahlam is saying block. I don't see here here a block. I don't see here an AV block. It's just a low voltage ECG. So yes, it can be due to a fat person, exactly as Ali is saying. So how to define a low voltage ECG? We have a definition. So when the QRS in the limb leads, so in lead 1, 2, 3, AVR, AVL, and AVF, the QRS is less than 5 millimeters. When we measure it and it's less than 5, so here is a criteria to define a low voltage. Or if the amplitude of the QRS in the precordial lead, so V1, V2, V3, V4, V5, V6 is less than 10 millimeter, is also due to low voltage. So we say here we have a low voltage ECG. We have a lot of causes of low voltage ECG, as Ali said in the chat. The most common cause is obesity. So when we have excess fat, I will show you the pointer. So when we have excess fat, the distance between the electrodes and the heart will become wider. So you will detect it on the ECG by seeing low voltage. Other common causes are pericardial effusion. So when we have the pericardium is filled with fluid, in that case, also the distance between the heart and the electrodes will become bigger. So you can think of pericardial effusion. In that case, also you need to do an echo to assess the pericardium. Other causes are lung diseases like pneumothorax pleural effusion, because we have also increase in we have more air between the electrodes and the heart, so it will also cause low voltage. So we have a lot of causes, and this tool will allow you to differentiate between all the differential diagnosis. Here is another condition which we call electric alternance. Can someone tell me on the chest X-ray what are you suspecting here when you look at this chest X-ray? On the left, what do you think the problem here is? So when you look at it, we look on the heart mainly. How can you describe this heart? Okay, so yes, Afaf. So heart is enlarged, so it's a cardiomegaly. So it's either the ventricles are dilated or the pericardium is filled with fluid. So in that case, this patient, he had a massive pericardial effusion. So yes, it was a tamponade, exactly, Ahlam. So it was a tamponade. So if you look on this ECG, you have a sign that we can sometimes see in tamponade or massive pericardial effusion. We call it electric alternance. So if you look on each QRS complex, you can see the arrows, the blue arrows. Each one has a different amplitude. When we see this, you need to suspect that there's a massive fluids around the heart, and the heart is swinging inside this fluid. So like a ball that is moving inside a massive fluid. So when the heart will move, the ECG will detect a different amplitude of the QRS because the heart is moving inside a cavity that is filled with fluid. So when you see this sign, and we see low voltage as well, you can see here we have a low voltage as well. So here we directly need to send the patient to the echo lab and to drain the pericardial space in order to alleviate the tamponade, so the compression on the heart cavities from the pericardium that is filled with fluid. So we said before we need to know if the P wave is present or absent to differentiate between sinus rhythm and between atrial fibrillation. So in atrial fibrillation, sometimes you can see small notches. These are not true P waves. These are fibrillatory waves. So these are like artifacts or notches. We should not consider these as P waves. Another example, you can see different examples of atrial fibrillation, or atrial flutters. Or we'll not go into details on atrial flutters now, but you need to just know the atrial fibrillation is an irregular rhythm with absence of P waves. So there's no P waves. Another important criteria to know on a surface ECG is to know how to measure the heart axis. So the heart axis reflects the combination of direction of deposition of heart vectors during the inside the cardiac muscle cells. So we always need to measure the heart axis, because heart axis would give us a lot of indications if the patient has a normal heart or an abnormal heart, a structural heart disease. So you need to know, sometimes you hear we said it's a positive QRS. So we said positive QRS when the positive deflection is bigger than the negative deflection. So R is bigger than S, so this is considered a positive QRS. When it's equal, we call it equiphasic QRS. And when the negative portion is bigger than the positive portion, we said that it's a negative QRS. This is important when you want to know the heart axis of the patient. This is a representation of all heart vectors. So we have the heart electrodes, we have the heart leads, the limb leads, 1, 2, 3, AVF, AVL, and AVR. So the normal heart axis is when the summation of all vectors is between +90 and -30. When we have the vector between the heart vector between these numbers, it's a normal axis. When it's between -30 and -90, so it's a left axis deviation. When it's between +90 and 180, it's a right axis deviation. And when it's between -90 and +180 is an extreme axis deviation. I will show you a few examples. So you always, when you look on the ECG in order to know the axis, so you need to look at 3 leads: lead 1, lead 2, and lead AVF. You just need to look at these 3 leads in order to know the axis. So when lead 1 is positive, lead 2 is positive, and lead 3 or lead AVF is positive, in that case, as you can see here, so lead 1 is lead 1 is positive, this one is positive, lead 2 is positive, and lead AVF is positive. So if you look on these vectors, so here the lead 1 is here, it's positive here, lead AVF is positive here, so the resultant vector will be somewhere here, so it will be between +90 and -30. So when we have this, we said that we have a normal heart axis. While here, on the second example, we have a positive wave in lead 1, but we have a negative wave in lead 2, and we have a negative wave in lead AVF. So if we look on the graph here and do the vectors, so positive in lead 1, it's here, negative in lead AVF is somewhere here, and negative in lead 2, so it's somewhere here. So the resultant of these 3 vectors will be somewhere here between -30 and -90. So in that case, we're in the left axis deviation. As opposed to the right axis deviation. So the right axis deviation, you will have a -1, then a positive in lead 3 and AVF, and positive in lead 2. So when we have a negative vector in lead 1, so we're here, and a positive in lead AVF, so we're here. So the resultant vector will be somewhere in between. So it's between +90 and +180. So it's a right axis deviation. Usually you see a right axis deviation in conditions that related lung conditions like chronic obstructive pulmonary disease, like pulmonary hypertension. Anything that is causing right heart strain can sometimes give us a right axis deviation. So it's very important to know how to know the axis of the heart, because it can give us clues in order to reach the diagnosis. For example, here we should suspect lung disease or right ventricular disease. Well, if we have a left axis deviation here, we need to suspect other pathologies. We suspect an ischemia, because ischemia can sometimes cause a left axis deviation. So it's very important to know it. So to resume it, when we have positive lead 1, positive lead 2, and positive lead AVF, it's a normal axis. When we have positive lead 1, negative lead 2, and negative lead AVF, it's a left axis deviation. When we have a negative lead 1 and positive lead 2 and positive lead AVF, it's right axis deviation. So it's very important to know how to differentiate between normal axis, left axis, and right axis, because it will orient us to a lot of different pathologies. Now we will focus on talking about P waves, QRS, and T waves, each one alone. So the P waves should always be upright. So it should be a positive wave in lead 1, 2, and should be always inverted in AVR. If we see a positive wave in P wave in AVR, so it's either the leads are misplaced or there's something going on in the heart. We need to suspect a proximal occlusion of a coronary artery. So we always need to look for positivity of these P waves. And we need to know that it should always be negative in lead AVR. And the duration of the PR interval, so the depolarization of the atria, should be less than 120 milliseconds, so less than 3 small squares. So the PR interval should be less than 3 small squares. And the amplitude of this P wave should be So if we measure the amplitude, so if we how much it goes up, it should be less than 2.5 millimeter in the precordial lead, so from V1 to V6, and less than 1.5 millimeters in the precordial leads, sorry, and 2.5 in the normal leads. And to evaluate the P waves, the best leads to look at are the inferior leads, so 2, 3, and AVF, and also lead V1. So these are the best leads in order to evaluate the abnormalities of the P waves. So what does the P wave represent? So the P waves is here. You can see we zoomed on it. So the P waves, it has two portions, but we usually don't see these portions because they are fused. But when we go deeper, we can see that the P waves contains two portions. The first 1/3 of the P waves, they correspond to right atrial activation. So when we have right atrial activation, we'll have the first portion, but while the second 1/3 are the left atrial activation, and the middle is a combination of both, because we said that the P wave is the depolarization and contraction of the both atrium, right atrium and left atrium. So we should see both inside this P wave, but because they are fused, we usually don't see them both. And the PR duration, so the distance from the start of the P wave to the start of the QRS segment should be less than 120. Sorry, it should be less than. It should be between. Here it's wrong. It should be between 120. So it should be between 120 to 200 milliseconds, the normal PR interval, and the amplitude should be less than 2.5, as we said previously. So when we have right atrial enlargement, so here we will start to detect it on the P wave. So once the right atrial enlarge, so the right atrial depolarization will become bigger and will overlap the left atrial depolarization. So when we see that the amplitude got bigger, above 2.5 millimeter, and you see this shape, so you need to here think of right atrial dilatation. So when you see this shape, increase in amplitude and the right atrial extends to involve the left atrial wave, so here you need to suspect right atrial enlargement. While the left atrial enlargement, you will see another shape, we call it the P mitral. It's a biphasic shape of the P wave. You can see two notches in the P wave. So it's very important to detect these things. So here is the normal shape. I said you always need to look at lead 2. This is the most important lead. So when we have right atrial enlargement, you will see increase in amplitude of the QRS, of the P wave. When you have left atrial enlargement, you will see a shape like a biphasic P wave. And when we have a combination of both, so right atrial enlargement and left atrial enlargement, you will see also a combination, so increased amplitude and biphasic P waves. You see you see these conditions in cases of atrial fibrillation and cardiac amyloidosis cases. So we see atrial enlargement in a variety of conditions. Noah is asking me to talk a bit in Arabic. Okay, I will try. راح أجرب أحكي شوي زيادة عربي. هون you can see we need also to look at P waves if it's inverted or it's usually we said the P wave يعني P waves على طول لازم تكون positive except in leads AVR. But when we see inverted P waves, so P waves going down, it should be like this. Here it's going down. So here we need to suspect a non-sinus origin. يعني P wave here is not originating in the SA node or in the atria. So it's a negative wave not originating in the sinus origin. So it's an ectopic origin of these P waves. And when the PR interval, so when we measure the PR interval, so from the start of the P to the start of the QRS, is less than 120 milliseconds, يعني أقل من 3 small squares. So it's here it's the origin is the AV junction. So it's a junctional origin of this P wave. You will see the topic on junctional rhythms by my colleagues on next presentations. When the PR interval is above 120 milliseconds, so if you measure أول الP لأول الQRS, if you see if it's above 120 milliseconds, so above 3 small squares, so here it's the origin is the atria, within the atria, so it's above. Sometimes we have conditions that can cause us variable P wave morphology. So we have, if you look closely here, you have this P wave. I'm trying to put the pointer. This P wave is different than this P wave, is different than this one, different than this one. This one is inverted, different than this one, and different than this one. So we have here about عندنا 5 shapes of 5 shapes of P waves. So and the rhythm is a bit irregular because the duration between here to here is not the same. The duration between here to here and not the same, so it's irregular. When we see بس يكون عندنا above 3 P wave morphologies, so when we have more than 3 Q wave morphologies and irregular rhythm, here we need to suspect something called multifocal atrial tachycardia. So we have multiple focus generating these impulses. We usually see these conditions in lung diseases like chronic hypoxia or hypoxemia. When the oxygen drops, we'll have generation of new areas of automaticity. So in that cases, here we need just to supplement the patient with oxygen, which we don't have to give anti-arrhythmics. So we need to give oxygen. So it's a multifocal atrial tachycardia here. It's not a block. It's not a cardiomyopathy. It's a multifocal atrial tachycardia in that case. So sometimes we see Q waves. So Q waves are the first negative waves in the QRS complex. So here it's a small Q wave, small Q wave, small Q waves. So normally we should see them in lead 1, AVL, V5, V6. We should always see Q waves in these areas. When we don't see these Q waves, it's pathological. But just need to know that we need to always see them in 1, AVL, V5, and V6. When we say that we have a significant Q wave, so when the Q wave is significant when it's wider than 30 milliseconds or 0.03 seconds, so it's a bit wide, and when it's when the length of it is more than 1/3 of all this complex. So it should be a bit wide, so it should be 30 milliseconds or 0.03 seconds, and it should have an amplitude of 1/3 of all the QRS complex. When we see this, we say that it's a significant Q wave. And when you see a Q wave, it usually indicates a previous myocardial infarction. So you should know that this patient most probably had a myocardial infarction in the past because it's a sign of a previous ischemia. So we'll not repeat it. We said it. It should be wide and should be tall. And the differential diagnosis most commonly is myocardial infarction. We can see it also in hypertrophic cardiomyopathy. We can see it sometimes if the leads are misplaced. It's very important to be careful on how to place our electrodes. So, but mainly it's seen in old myocardial infarction. Can someone tell me here if we have a significant Q wave or not, and in which lead can we see it? Please, someone write it in the chat box. Where do you see the Q wave here? In which lead? Okay, so if you look closely on lead 3, you see. Okay, Ahlam is saying me lead 1, Nadia is saying lead 2. I got many answers, 2 answers saying lead 1. Yes, we have a small Q wave in lead 1. You can see here it's a small Q wave in lead 1, and in lead 2 also we have a small Q wave. But as Ali said, the most significant Q wave is here are in lead 3. and in lead AVF. So if you look here at the lead AVF, you see that the width is 1 small square, so it's 40 milliseconds, so it's significant. And the length is more than 1/3 of the total QRS complex. So here it's a significant Q wave, and if you look closely to the ST segment that we'll discuss a bit later on, you see that the ST segment is elevated. So this is a myocardial infarction. The ST segment elevated in lead 2, lead 3, and lead AVF. So it's an inferior myocardial infarction. So here we find that the right coronary artery is occluded. So we have the development of Q wave with ST segment deviation. So here it's an ischemia. It's a typical pathologic Q wave because it's wider than 40 milliseconds and it's more than 1/3 of the total QRS length. And now we'll talk about the T waves. So the T waves is the third part of the QRS complex. It represents ventricular repolarization. So here is the ventricle, it's relaxing, it's getting filled with blood. So it will be detected on the ECG by the T wave. So the normal T waves they should always be positive, except in leads AVR and in lead V1. So always positive except in these two leads. And the amplitude should be less than 5 millimeters in limb leads and less than 10 millimeters in precordial leads. So when we have a lot of T wave abnormalities, mainly the peak T waves and the hyperacute T waves, which we see a lot of times, and the inverted T waves. So these are the three most important types of pathologies associated with T waves. Can someone tell me here what are we seeing exactly? So this is the T wave. This is the T wave. What do you think here is the problem with this T wave? These are the T waves. What do you think is the main problems here? So here the T wave is tall, yes, it's tall and it's narrow. Okay, but mainly it's tall here. So we should see that this is a it's a peak T wave. So we see this in when it's symmetric and tall. We see it in the cases of hyperkalemia. So here's the potassium level is above 6. So here is a hyperacute T wave. So hyperacute T waves can also be seen in myocardial infarction, not just in hyperkalemia. So also myocardial infarction can cause hyperacute T waves, so tall T waves. But in myocardial infarction, usually they are asymmetric, as opposed to the hyperkalemia, which is asymmetric. So if you put a midline, here, it's symmetrical, while here it's less symmetrical. So it's a way to differentiate it from the two conditions. Inverted T waves as well. So here you can see in lead 2, 3, and AVF. You can see that we have, I think the pointer, you can have inverted T waves in these leads. So this is condition usually associated with also ischemia. Sometimes it can be present in hypertrophic hearts, but usually when you see this, you will need to suspect a myocardial ischemia, especially if you compare to an old ECG and you don't find it on an old ECG, you need to suspect ischemia. U wave is not very important. I will move from it. So sometimes you need to see, you see on the ECG something we call a J wave or Osborne wave. So it's like a small notch just after the QRS complex and before the T wave. So when you see this J wave, usually it's associated with what? It's associated with hypothermia. So when the temperature drops, so patient is drowning. So they took a patient that was drowned in the pool or in the ocean, and you do an ECG. If the temperature is low, especially below 30 degrees of the patient, you will detect it. It's a diagnostic tool to detect hypothermia. So here you see it clearly. It's a J wave or Osborne wave. Here the patient had a temperature of 28 degrees. He was severely hypothermic. So here we need to rewarm the patient and administer the rewarming tools to reverse it. The PR interval is from the start of the P wave to the start of the QRS. So the PR interval, as we said, should be between 120 and 200 milliseconds. So between 3 small boxes and 5 small boxes. And when it goes up above 200 milliseconds, it suggests first-degree heart block. We will see it on the next lecture. And when the PR segment is less than 120 milliseconds, it's also we see it in other junctional rhythm or pre-excitation rhythm like Wolff-Parkinson-White. We will not go into these details now. So the PR interval is also very essential in diagnosing acute pericarditis. So if you see here, this is the baseline. So you see that the PR segment is below this line. So when we see this, you call it a PR segment depression or PR segment elevation in the next one. Here is an elevation, here is a PR segment depression. These findings are associated with acute pericarditis. Acute pericarditis is an inflammation of the pericardium. Usually it's due to a viral infection. So the ECG also can detect it. And when you see it, you need to do echo in order to eliminate pericardial effusion, because you will see sign of acute pericarditis sometimes on the echo. QT interval, we already discussed it, but I just need you to know that to measure the QT interval is from the start of the QRS segment to the end of the T wave, not from the end of the QRS to the end of the T, from the start of the QRS to the end of the T segment. So this is how we measure it. So here is a picture that shows you how to measure it, but you need to know that the QT is always influenced by heart rate. So the QT is shorter when you have faster heart rate, and the QT becomes longer when you have slower heart rates. So there's a formula which we call the Bassett formula. It's usually used to calculate the corrected QT. It's QTC equal to QT divided by radical of RR. So it's the Bassett formula to accurately calculate the QT. So the QT here is the QT that we measure on the ECG divided by radical RR, so the duration between two RR complexes. So we say it's prolonged if it's above 440 milliseconds in men or above 460 milliseconds in women. And when it's above 500 milliseconds, it's a very high risk of developing torsade de pointe or polymorphic ventricular tachycardia. We said in the first lecture that when we see this, so if you look at the ECG below, you see that the QT segment here was wide. Then a premature beat occurred, and after that, we had a pause, further prolongation of the QT segment, because we said that when you have a slowing of the heart rate, the QT segment will prolong. And after that, we had initiation of a torsade de pointe, which is a polymorphic ventricular tachycardia. So it's a very dangerous condition here. So the causes, we said before that we have congenital causes of long QT, like long QT1, long QT2, long QT3, and each type of these syndromes are triggered by an external stimulus. Other more common conditions are electrolyte disturbances like hypokalemia, hypomagnesemia, hypocalcemia, and hypothermia. Also, myocardial ischemia can cause it, and a lot of medication and drugs like antibiotics, antipsychotics, antiarrhythmics. So a lot of medications can induce it. We have two different shapes of QT prolongation. If you look on the first ECG, for example, if we look here, the QT segment here is prolonged, but here the ST segment is prolonged. The T wave has a normal shape, as opposed to the second ECG. Here is the T wave is wider, so that's why we have widening of the QT interval, because the T wave got wider. The first one is the segment that got wider, but the T wave is still normal. It's important to know the difference between these two entities. The second one is associated with hypocalcemia and hypothermia. Only hypocalcemia and hypothermia can cause this shape, while all other conditions will cause prolongation of the whole segment, not just the T wave, which will become wider, as in the case of hypocalcemia and hypothermia. Sometimes we have another conditions like shortening of the QT segment. Usually this is due to a congenital syndrome, which is we call short QT syndrome. This is also predisposes the patient at risk of developing atrial or ventricular fibrillation. You can see here the QT segment is very short. It's less than, it's about 260 milliseconds. So here it's a risk the patient develop atrial or ventricular fibrillation later in life. Moving now to the ST segment. So the ST segment is the segment that from the end of the QRS to the end of the T wave. This is the ST interval. This is the most important interval when we look on the ECG, because when we see changes in this interval, we need to suspect myocardial infarction or acute coronary syndrome. So we always have to look at it. You can see here, for example, these are the different shapes of ST segment elevation. You can see that the ST segment here is elevated. This is a ST elevation myocardial infarction. We have here also ST elevation, ST elevation, ST elevation. So we have different shapes of ST elevation. So when you see this shape, you need to send directly the patient to the cath lab and do a coronary angiogram to check if his arteries are blocked or not. So not only acute myocardial infarctions, we have other causes like coronary vasospasm, pericarditis, ventricular aneurysms. So we have a lot of conditions that can cause elevation of the ST segment. Can someone tell me here what is the cause of what is the diagnosis on this ECG? What do you see here exactly? Do you see any ST elevation, and in which leads, please? Oh, okay. So if you look closely to the ECG, yes, Ali is saying STEMI in V1 to V4 exactly. So we have ST elevation, especially in V2, V3. Yes, Ahlam, true, and the V4, V5 as well. So here we need to suspect. Yes, Nadia is also saying ST elevation V2, V3, V4, V5. We need to suspect here anterior myocardial infarction. Usually this territory, so when we see V2, V3, V4, ST elevation in these three leads, you need to suspect anteroseptal and anterior wall myocardial infarction. Usually this is due to blockage in the left anterior descending artery. So also it's we need to suspect stenosis in this vessel. So to summarize, ischemic changes, sometimes even if we have ischemia, the ECG can be normal. So even if the vessel is blocked, the ECG can be normal. Sometimes we can have Q waves. Sometimes we can have T wave flattening or T wave inversion, or new onset positive T waves that was previously negative, or ST segment depression, or ST segment elevations. Or all of these conditions can be attributed to ischemic changes. Okay, I just want to, I don't have a lot of time remaining. I just want to show you this ECG. Can someone tell me what do we see here? Is it a wide QRS or is it a narrow QRS? What do you think? This is the last ECG that we will show today. So it's a wide, yes. It's a wide QRS. What do you think is the problem here? Why is the QRS got wider? True, it's a wide QRS. I want you to look closely. I will zoom. So if we look closely to the QRS, before the QRS, you can see a small notch. When you see the small notch, usually the patient has a pacemaker. So yes, exactly. Nadia is told the correct answer is a pacemaker rhythm. So when you see a notch before the QRS, you should also check if the patient has a pacemaker or not. So always when you have a widening of the QRS, so first you need to suspect bundle branch blocks, right or left. But also you need to think of the presence of a pacemaker, because when you have a pacemaker, the QRS will become also wider. Okay. Okay, so I think okay, I will show you one more ECG. This is the last one, and we'll end the presentation here. Can someone tell me here what is what could be the patient condition? I will zoom in on this lead, the last one. Someone can tell me what is the cause here? What do you think is the cause? So first is it's a narrow QRS here. It's not a wide QRS in that case. Do we have P waves or not? We have P waves or not? Yes, Afaf told me no. Yes, we have told P waves. Yes, we have. Look well at these P waves. So here it's a P wave. 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 What do you think is? Yes, it could be P mitral. So it's enlargement of the atria. But here we have, yes, Alice said the correct answer. It's a multifocal atrial tachycardia. So why it's a multifocal atrial tachycardia? Because we have 3 or more P wave shapes. So you can see that each P wave is different than the next one, and the rhythm is irregular. So here, the duration from here to here is different than the duration from here to here. It's a bit irregular. So it's a multifocal atrial tachycardia, and we said that it's associated with what conditions? So yes, Nadia, P wave morphology is changing. It's true. So this is the criteria for multifocal atrial tachycardia. It's associated with what condition? Anyone know? So when we see this, we need to suspect hypoxia or lung disease causing chronic hypoxia. So here we don't give antiarrhythmics, we just need to give oxygen to the patient, and we will reverse it. So just by giving oxygen. And that was it. It was, I just want to mention the source. You can check this this tool. It's found on the internet. It's a very, very interesting tool. If someone is interested to go more in the details, you can check it. It's very interesting. And by this, I end my presentation. If you have any questions, you can ask me on the chat box. And thank you for listening.
Good morning, everyone. Assalamu alaikum. Good morning. Can you hear me? هل تسمعون الصوت؟ الصوت واضح والصورة واضحة؟ Okay. Okay, good morning and welcome to the webinar. Thank you for the organizing committee for the invitation for the webinar. And we will start our first session with already what Dr. Antoine started for the ECG. We are going to give a case scenario, and we will be talking more about the atrial and ventricular rhythm and the block, and we will be giving a real case scenario. فإذا احنا نتكلم عن اشياء quick review about the ECG, what was given, and atrial and ventricular rhythm. As you know that ECG there is components. يعني نحن, for example, if you have a patient, to say a patient he is vitally or hemodynamically stable, there is component that needs to be available. Now, for example, a patient, if he's tachycardiac or bradycardiac patient, it doesn't mean that the patient is going to die, but there is something which is not going well. يعني المريض, if he has hemodynamically unstable, he has tachycardia, دقات قلب سريعة أو دقات قلب منخفضة, أو hypertension or hypotension or whatever, it doesn't mean that the patient يعني he is not doing well, but at the same time I couldn't say that he is in the critical condition. Here for ECG, the risk components should be available. Now, P, Q, R, S, T. Sometimes we might have a problem with the P or PR or RR. This is the components. What this means there is problem that we need to identify, we need to treat it, but it doesn't mean that the patient is in a critical condition. وين بنقول المريض he is a highly critical condition or life-threatening condition وقتها بنفوت بالشكبل rhythm which is the pulses VTAC and VF that you are going to see. فإذا المريض ممكن يكون in a tachycardia، ممكن يكون in bradycardia، ممكن يكون in a tachycardic rhythm ورح نشوف يعني like supraventricular tachycardia, atrial fibrillation, atrial flutter. We will see the line of treatment. ممكن يكون على براديكاريا not treated يروح على بلوك اللي هنشوفها بعد الظهر، وممكن يكون على shockable rhythm where there is no P, no Q, no R, no S, no T. I cannot identify anything. Okay, وممكن يكون asystole or PEA. We will be seeing all this slide short. طيب خلينا نبلش هون. إذا بنشوف what do you mean by sinus rhythm. وقت بنحكي بكلمة arrhythmias, what do you mean by arrhythmias means abnormal rhythm. يعني ممكن يكون إذا tachycardia it's arrhythmias, bradycardia it's arrhythmias. فإذا here sinus rhythm, how we could identify it. Here, let's say, first of all, we need to identify the component, which is P. If you will see to the rhythm here, the P are available. I have the P here. Q, R, S, T. P, Q, R, S, T. P, Q, R. إذا بنشوف نحن الريزم هنا بنشوف إنه كل الكومبوننتس تبع الإي سي جي already available. Yes or no؟ يعني أنتم شايفين في شيء حسب رأيكم. Could you see any components of the ECG which is not available؟ يعني أنا عندي ال P وال QRST. هذا for the first impression sorry. All the components are available. Yes or no؟ إذا كل الكومبوننتس. طيب شوف الخطوة الثانية ال PR interval. You know in the critical condition أو ب critical situation ما بيكون عندي الوقت اجلس واخذ المقياس no you should inspect. يعني من خلال النظر لازم نشوفه. إذا بنشوف هون ال PR interval حسب رأيكم it's short يعني كتير ضيقة or it's long. لا I could see it as a normal. ودائما ال PR interval بكل ال ECG هون بكل it's the same. يعني إذا بشوف المسافة من ال PR لهون هلا وقتها بتصير long PR بدي بلش شوف انه I will be start talking about a block. واذا بشوف a very short PR بدي بشوف انه rhythm it's very fast مثل supraventricular tachycardia. هون ال PR I could see it that ما it's not short it's not long. ال P it's not inverted or converted. وكمان ال QRS مثل ما حكيته بالسيشن اللي شفته مع الدكتور أنطوان بالسيشن ال QRS it's not wide normal. والار ار اتس regular. يعني بنشوف اذا المسافه من الار لار هنا this is similar this is similar this is similar this is similar. فاذا كل الكومبوننتس of ECG are available first. مثل ما بحكي المريض he has a heart tachycardia, he has a heart rate, he has a blood pressure, he has temperature. This is the same. Now مريض عنده tachycardia, مريض عنده hypotension whatever, take the same example of the ECG. عندي كل الكومبوننتس available وكل الكومبوننتس المقاييس تبعها it's normal. Here what I could see والrate how I will calculate it. كيف do you know how to calculate the rate? Any idea كيف ممكن أعمل calculation الريت؟ عد الR 1 2 3 4 5 6 6 to 7. فإذا 7 multiply by 10 قديش بنكون 70. 70 this is a normal لأنه إذا كان تحت ال 60 بلش احكي عن البراديكارديا. اذا بعد فوق ال100 بلش احكي عن تاكيكارديا. هون الريزم 7 by 10 which is 70. ايش بقول عليها؟ this is a normal sinus rhythm. يعني بالنورمال sinus rhythm I have all the components of the ECG are available. First, all the components of the ECG are normal من شكل ال P من ال PR من ال QRS من ال RR, and if I will calculate the rate it should be 60 to 100 which is here 70 فإذا بضمن الافريج I will say that's a normal sinus rhythm. كمان وقت نحكي عن البي ار انترفال مثل ما حكينا بدها تكون 0.12 to 0.20 seconds مثل ما تكلمنا بالemergency situation there is no time to calculate it, you will see it. يعني أنا مش شايفها لا كتير long ولا short والكيو ار اس it's not wide. Clear for the sinus rhythm. إذا وقت بحكي عن الساينس rhythm this is how I could identify it. Any question about the sinus rhythm قبل ما لأنه لازم تعرفوا البيزك، إذا ما هيك ما فينا نروح على الأشياء الأدفانس. فإذا do you have any question about the basic one? Sorry. Okay, great. طيب بنروح على القسم اللي هنا ألا وهي البراديكارديا. إيش الفرق هنا؟ كمان بدي أروح معكم على البيزك كومبوننتس. فإذا أول شيء مثل ما تكلمنا بتطلع أنا على البي بي 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 بي. فإذا البي followed by QRS. هيدي ال QRS. Here the P it's followed by QRS. P it's followed QRS. The PR interval ما شايفها كتير. I could see it between 0.12 0.27. ال QRS كمان it's not wide. مش شايفها انه واسع اكتر من 0.10 seconds or less. طيب what do you think what is the problem here؟ ايش عندي المشكل هنا بال ECG؟ What is the problem here؟ Where is the problem here؟ وين المشكلة؟ The problem, if I will count the RR 1, 2, 3, 4, 5. 5 multiplied by 10, it's 50. 50, it's less than 60. فإذا 50 I will identify it هون. فإذا عندي a sinus bradycardia. كل ال components, all the components are available. وكل شيء مضبوط، ما في عندي أي مشكل. The only problem that I have if I will count the RR 1, 2, 3, 4, 5 وضربها ب 10 it's 50. فإذا it's sinus bradycardia. Okay. Now, do you think what are the causes of sinus bradycardia؟ أكثر شيء هي ممكن تكون myocardial infarction, hypothermia, hypothyroidism, electrolytes imbalance, and medication, you know, like Digitalix and whatever. فإذا هيدي how we could treat. Now, you know, what are the يعني كيف بعرف المريض عنده sinus tachycardia؟ دائما we need to know that mainly with hypotension, chest pain, shortness of breathing, changing in mental status, and هاي اللي حنشوف. طيب في كتير مهمة نحن لازم نعرفها موضوع الانترفنشن. Now for all the rhythm بالأخص non-shockable بالintervention we need to know something that's applicable to all. يعني في مبدأ that's applicable على كل الساينس أو على كل الأريزمياز إلا إذا كان المريض بيكون على ناحية الشوكبل. هون شوكبل ريزم مثل البالسز فيتاك والفي اف. هون الموضوع بيختلف بيروح على line of treatment that we are going to discuss it يعني in this session. But here سواء عندي a tachycardiac or a bradycardiac I have the same approach which is I have a stable unstable patient or unstable. يعني بمعنى تاني ممكن يجيني مريض انه I connect the patient to the monitor and he has a bradycardia but he's stable. يعني ما في عنده اي مشكله. يعني صحيح عنده low heart rate but he's ما في عندي اي signs and symptoms showing that he is in a critical condition. What to do إذا أجاكم مريض عنده sinus tachycardia but he is stable, what will be your role؟ إيش نسوي؟ What to do؟ What types of intervention it's required from your side؟ As in here at this point I need to keep the patient under close observation. ده اللي راقبه لأنه المريض if patient is stable فإذا Excellent. فإذا I need to observe. I need to keep him under close observation. لأن المريض at any time, at any minutes, he might become unstable. فإذا I will keep him under close observation because at any time he might become absent. طيب إيش هي العلامات or what are the signs and symptoms showing that my patient he become unstable. هون برجع على اللي حكيناها أهم شيء بالسلايد اللي قبل، ألا وهي signs that مريض بيصير عنده bradycardia، أهم شيء hypotension and decrease level of consciousness. إذن هون وتبقول المريض he is unstable bradycardia isolated but I will keep him under close observation. What are the فإذا no treatment, keep him under close observation. Now if the patient he is unstable شو بتعطيني what are the signs هي معظمها hypotension و decreased level of consciousness. بهالحالة I need to interfere and start the intervention. Now يعني أنا symptomatic كيف ببلش مش ببلش بالأتروبين ابنفرين دوبامين اند البيسنج رح نشوفها، ما رح سبق على زميلي بعد الظهر، رح نشوفها بموضوع البلوك. فاذا مينلي وقت المريض بحس انه عنده he start having unstable bradycardia, the line of treatment will be starting with the atropine, epinephrine, dopamine and pacing وتفسير بموضوع الهارت بلوك which is going to be discussed in the afternoon. فاذا this is the primary intervention for a sinus bradycardia. Now sinus tachycardia. What is the problem here with this rhythm? ايش لاحظتوا هنا بهذا الرhythm? What are the difference between sinus bradycardia, normal sinus rhythm or sinus bradycardia and sinus tachycardia? What are the difference here? ايش وشو لاحظتوا الفرق هنا؟ إذا بتطلع على ال components which is PQRST يعني بشوف أنا أوكي. فإذا المسافات قريبة ومنتظمة. طيب أنا دائما مثل ما حكينا الابروتش always start with the basic اللي هي الكومبوننتس موجودة PQRST 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 موجودة. فإذا أنا ما في عندي ما في عندي أي شيء من الاي سي جي هون الكومبوننتس مش موجودة. هاي أول شغلة. الشغلة الثانية والأهم الار ار منتظمة، طبعا منتظمة يعني الار ار بتشوفوا على نفس المستوى. What is the problem here? I will count the R to see the problem. I have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. فإذا أنا I have 12 R. إذا شفنا بالساينس براديكال ده كان عندي 5 R. By 10 it's 50. 12 R. By 10 it's 120. 120 شو يعني؟ It's a very fast rhythm. I will call it a sinus tachycardia. عرفتوا شو المبدأ؟ يعني very important تتعرفوا كيف how to interpret البيزك، لأنه later on بصير كل شيء هين. فإذا هون أنا عندي 120 by عندي 12 by 10 it's 120. 120 it's sinus tachycardia. شو لاحظت كمان أنا؟ بنشوف إنه الريزم يعني لأنه 120 بنشوف إنه الريزم very fast يعني بتشوف ما بيحق بيخلص إلا بيبلش. very fast rhythm. then here what we call it a sinus tachycardia. مثل ما شفنا في الريت sinus tachycardia rate it's very high ممكن يوصل لحد 150 but it's regular. ال P wave as you see it's uniform in appearance يعني نفس ال P بأي ريزم it's the same. ال PR interval it's 0.12 to 0.20 وال QR duration it's 0.10 seconds or less. فإذا كل ال components والinterpretation وكل شيء بالاي سي جي هون it's normal. بس المشكلة الوحيدة عندي I have a very fast rhythm. كيف عرفت انه very fast rhythm؟ وقتها I count ال R وضربتها ب 10 طلع عندي 120 and this is what we call a sinus tachycardia. Now what are the cause؟ أكثر شيء بنشوف الساينس tachycardia عند البيدياتريك. ليش؟ ليش؟ لأنه يعني معظمهم بيكون التاكيكارديا بيكون عندهم due to the fever وبيكون عند البين وإلى آخره. يعني ممكن تشوفوا مريض he has a severe pain حتى adult he end with tachycardia or fever يعني الفيفر بالأخص عند البيدياتريك they will end with a they will have tachycardia. Now what are the cause of sinus tachycardia؟ مثل ما حكينا high fever pain anxiety كافيين. اللي بتشوف نحن بالأخص اللي بيشربوا كافيين بشكل كتير كبير بيحسوا بيقول لك أنا بحس بخفقان بالقلب. مظبوط؟ أو دقات قلب سريعة. ممكن يكون one of the leading cause هي الكافيين. يعني إنه ممكن يكون سبب من الأسباب إنه الشرب المفرط للقهوة بشكل كتير كبير. القهوة اللي بيشرب يعني كمية لا بأس بها من القهوة ممكن يكون هذا سبب من الأسباب that the patient he might end with أو هي بيكون عنده عوارض التاكيكارديا. بيقول لك المريض أنا حاسس بخفقان بالقلب أو بدقات قلب سريعة. فإذا الكوز ممكن يكون الإكسرسايز اللي بيعمل طبعا اللي بيركض العدائين يعني which is والميديكيشن ممكن تسبب على الميديكيشن like epinephrine atrophy. Now once it will come to the intervention, do you think what will be the intervention for a sinus tachycardia؟ هلا ناخذ نفس الاكزامبل من الساينس tachycardia. Do you think what are the intervention for a sinus tachycardia؟ ايش هي الانترفنشن المطلوبة لمريض with a sinus tachycardia؟ What do you think؟ فإذا this is the same line of treatment. Observe the patient. يعني if the patient he is stable or my patient he is unstable. If my patient he is stable يعني he is اخذ كافيين مثلا عنده تاكيكارديا اوكي ما عنده اي علامات اخرى stable tachycardia we need to keep him for example under يعني close observation. If the patient he is unstable what are the signs and symptoms of instability؟ ايش هي العلامات اللي بتفرينا انه المريض عنده sinus tachycardia but he is unstable؟ excellent. tachycardia, hypotension and decrease level of consciousness. هذا من tachycardia, hypotension and decrease level of consciousness. Excellent. What will be the intervention here? Do we need to always correct the cause؟ يعني أنا إذا عندي مريض نتيجة البين tachycardia because of severe pain I need to treat to give a painkiller. If I have a pain نتيجة high fever I need to give medication to decrease the temperature. فإذا دايما أنا بتطلع على دايما بتطلع على السبب and I need to treat بدي أعالج السبب اوكي تروح العوارض. فإذا I need to treat the cause and this is يعني هيدي الصورة عن sinus tachycardia as you see كل الاشياء موجودة ما في عندي أي مشكل بس المشكل الوحيد إنه ال RR very fast. Sinus arrhythmias. What do you mean by sinus؟ How would you see the rhythm؟ شو المشكل بهذا الرhythm؟ لو say this is arrhythmias شو حكينا arrhythmias؟ What do you mean by arrhythmias؟ abnormal. شو معناتها sinus arrhythmias؟ How would you identify it and what is the problem do you think here؟ شو المشكل بهذا الرhythm؟ ودائما بلشوا من البيزك مثل ما تكلمنا. excellent. فإذا الirregularity كل الكومبوننتس عندها PQRST والRR available والPR interval والQRS PR 0.12 to 0.20 seconds والQR duration it's the same. بس المشكلة عنده إنه أنا عندي شوفوا المسافة هون شوفوا هي الRR كيف تختلف عن الRR التانيين. فإذا هون الRR interval it's long compared to the other. This is sinus arrhythmias. Arrhythmias abnormal, but everything is normal. You know, there is pulse, there is everything is normal, بس شو المشكلة الوحيد إنه it's irregularity. What do you think will be the treatment here؟ شو ممكن يعني السبب بتشوفه؟ يعني ممكن المريض يكون عنده isolated sinus arrhythmias. What will be the treatment؟ فإذا نحكي عن الأسباب what is the cause يعني associated with phase of respiration. أكثر شيء بنشوفها هيدي it's mainly observed in infant and child and heart disease. مش ما بنعتمد عليها كدليل على heart disease but it should be taken in consideration. okay. فإذا mainly intervention there is no intervention يعني mainly keep him under close observation and follow up later. But so far as intervention there is no intervention for a patient with sinus arrhythmias unless he start developing a other sinus. طيب رح بلش اعطيكم بعد الرزم مثل ما حكينا. فاذا نحن بنحكي عن تاكيكارديا كجنرال بس تحت التاكيكارديا في عنا بعد الرزم بنحكي عن البراديكارديا. البراديكارديا it might end with block. الشوكبل والنون شوكبل الشوكبل ريزم والنون شوكبل رح نشوفهم كمان ان شاء الله. بس هلا ليتس سي على التاكيكارديا ريزم مثل ما حكينا. طيب مثلا tachycardia حكينا عن الساينس tachycardia. Now what do you mean by other rhythm related to tachycardia? One of them is the supraventricular tachycardia. Do you think what is the problem here? شو شايفين أكثر شيء لفت انتباهكم بهذا الرزم؟ مثلا what caught your attention in this rhythm? what يعني هون شفنا واضحة إنه rhythm it's very fast. يعني إذا بدي أعدها 1 2 3 4 5 6 7 8 9 10 1 2 3 4 5 6 7 8 9 10 1 2 3 حوالي 250 R which is heart rate you could imagine patient heart rate more than 250. كمان شو لاحظت انه انا البي الكومبوننتس مش موجوده بس لانه الريزم فيري فاست ما بتلحق البي بتبلش الا بتنتهي. يعني بتشوفوا البي عشوائي فايته بالتي. اوكي فاذا بنشوف هون الريزم because the rhythm it's very fast here مش it's not absent يعني just for you to know the rhythm here it's not absent but because it's very fast ما بنشوفها. يعني ما بتلحق بتبلش الا بتفوت بالتي. يعني ما بيلحق ينتهي الريزم بالتي الا بتفوت عرفتوا كيف يعني here all the components are available because the heart rate is very fast. It will be very hard to identify the component of the rhythm. بتكون كتير يعني صعبة إنه أعمل identification لل components of the rhythm. مشان هيك يعني I would see that this is a supraventricular tachycardia heart rate P wave hidden in the T. يعني ال P wave بتكون متخبية بالتي. This is the intervention. فإذا هون هيدي التسمية المضبوطة. ال P موجودة بس هي مثل ما حكونا يعني مخبية أو فايتة بالتي. منشان هيك من الصعب علي جدا انه اقدر اعمل ايدنتيفيكيشن لانه كثير متقاربين على بعضهم نتيجه سرعه الرزم. بس الكيو ار اس اتس نورمال. Now, do you think what will be the line of treatment with patient with supraventricular tachycardia? What will be the line of treatment? Now again مثل ما حكينا same approach. If the patient he is stable or unstable. Now if the patient he is stable patient with tachycardia with a palpable pulse. Always I need to check the pulse لأنه we are treating a human being. ما بتطلع على الماشين. يعني أنا الماشين ممكن for a reason it might be give me a fault interpretation. بس دايما I need to see on the patient. I need to see the patient the pulse of the patient. بدي شيك على النبض المريض على pulse if it's available or not. فإذا very important to make sure that the pulse is palpable and patient stable. Apply the vagal manner, which is a technique by which you attempt to increase intrathoracic pressure will stimulate the nerve, you know, and we have many method, cuff method. This is a stable, which is many of the unstable. We need to go with the synchronized cardioversion, which is a low electrical voltage. Synchronized patient needs to be sedated. It's painful. يعني مش يعني synchronized cardioversion مش ماشي نخلطها مع الشوك delivery. It's the same concept إنه but here we will deliver a low voltage of electricity. Okay, فإذا بتنعطى بس synchronous cardioversion with patient with unstable tachycardia. shock بس بنعطى للمريض إذا كان عنده شك باريزموس pulses VTAC and VF. هون synchronous cardioversion بس for patient with unstable tachycardia. فإذا دائما بنبلش احنا intervention intervention are synchronous cardioversion while medication treatment which is starting with adenosine 6 milligram not successful يعني followed by adenosine 12 milligram and unstable patient with SVT and pulse are always treated. فإذا main line of treatment هو asynchronized cardioversion which is مثل ما حكينا it's a low voltage ممكن تبلش من 50 to 100 جول بينما بنشوف على البالسز فيتاك اللي في 200 300 360 جول. الموضوع بيختلف عند البيدياتريك لأنه البيدياتريك يعني بنبلش 4 جولز 4 جولز 2 جولز يعني 10 بير كي جي حسب الوزن وحسب كل شيء. بس هون إذا اللاين اوف تريتمنت هو السynchronized cardioversion while medication like adenosine and 6 milligram followed by 12 milligram. طيب هون مين ممكن يعمل لها interpretation للرhythm here? How would you interpret the rhythm? We call it a atrial flutter. What do you mean by this rhythm? Or how it could be interpreted? شو لاحظنا بهذا الرhythm؟ يلا waiting for your feedback. إذا no P wave. إذا هون thank you. إذا P wave no identifiable P wave. إذا ال P wave here it's very hard to enter. بما إنه ال P wave I cannot identify PR not measurable ما بقدر يعني إذا إنه الشغلة ما عم بقدر أعملها identification فإذا ال PR it's not measurable. I cannot measure it which is mainly مثل ما حكينا الميجرمنت تبع ال QRS usually it's less than 20 seconds. Rhythm it might be regular or it might be irregular. Mainly it's regular. وشفنا انه ال heart rate here it's very fast ممكن يوصل ل 250 to 350 beats per minute. And this is how we could interpret it. And the PR I cannot identify it and I cannot measure the PR interval but mainly it might be regular or regular. but الاتريال flutter it's mainly regular. رح نشوف شو الفرق بين الاتريال flutter والاتريال fibrillation. I will leave it to you بس شوفوا هيدا الريزم بشكل اسرع لانه معظم الناس بتصير او معظم البراكتيشنر بضيعوا بين الاتريال flutter والاتريال fibrillation which is it's going to be the similar line of treatment but بالايدنتيفيكيشن ممكن يصير يعني يختلف عند الموضوع. بس so far شوفوا هون شو هو how would you identify it. مثل ما حكينا الريزم very very fast. طيب الكوز ممكن تكون pulmonary embolism, thyrotoxicosis, ischemic heart disease, hypoxia, and digital toxicity. And this is the cause of a patient with atrial flutter. This is the leading cause that it might cause a atrial flutter for a patient. Management كمان this is the same line of treatment مثل ما لاحظتوا. هي الأشياء متشابهة. Stable we will give a anti-arrhythmia patient like amiodarone, calcium blockers, beta blockers, heparin and digoxin. ليش الهيبارين؟ حكينا عن موضوع انه pulmonary embolism it might be one of the leading cause. If the patient he is unstable بنعطي مثل ما حكينا هون as you see the synchronized cardio version and you know إذا هون شفتوا نفس الابروج على كل التاكيكارdia والبراديكارdia، بيختلف طبعا الانترفنشن والتريتمنت. فدائما بتطلع على stability of instability. دائما اجمال المريض atrial fibrillation supraventricular or flutter ما راح يكون السيف. بس سو فار دائما الميديكيشن تريتمنت اللي هو بيز على الانتي اريزمياز والسينكرونايز كارديوفيرجن. وحكينا هون نحن ترجع لكم بسلايد عن what one of the leading cause على الاتريال cause هي البلمونر امبوليزم. عشان كده مثل ما حكينا دخلنا على الانتي كواجوليشن الهيبارين مشان الكلوتينج. وتحكينا كمان عن الاميودارون which is 150 ملغ first 10 minutes followed by 360 ملغ over the next 6 hours infusion. فإذا this is طيب الاتريال فبريشن مثل ما قلت لكم رح ارجع شوف فيكم الاتريال فلتر فور 1 minutes قبل ما اروح على الاتريال فبريشن. لاحظوا وشو تعرفوا شو الفرق بانه مثل ما حكينا التريتمنت مينلي سيميلر. بس تقدروا تعملوا ايدنتيفيكيشن. هذا كويك لوك على الاتريال فلتر اوريدي شرحناها قبل ما اشوف فيكم على الاتريال فبريشن. طيب الاتريال فبريشن شو لاحظتوا هنا؟ What did you notice compared to atrial flutter؟ شو الفرق؟ excellent. اول شغله واهم شغله اتس irregular. هونيك معظمها ريجولار بس هون فاذا كيف نميز بين اتريال معظمها انه اتس irregular. شو لاحظتوا على البي؟ معظم الرزم اتس لايك a shape. مظبوط كمان. this is one of the no P wave and irregular rhythm. اذا هونيك no P wave but rhythm regular. هون no P wave ما بقدر اعمل identification. شوف مثل زي المنشار زي عرفتوا كيف زي النايف يعني كتير يعني and it's irregular لأنه مثل ما شفنا هون irregular 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 irregular. عرفتوا كيف يعني the rhythm here it's irregular. now شفنا الريت هون it's very يعني معقولة you could imagine that 360 bits per minute the يعني rhythm مثل ما حكينا it's irregular. the P wave not identifiable, PR not measurable and QRS is less than 1. شو السبب or what are the causes of this is coronary artery disease, congestive heart failure, mitral disease, hypoxia, drugs and electrolyte imbalance and hyperthyroidism والبلمونري embolism. رح تشوفوا كمان اللاين اوف تريتمنت it's mainly similar. بنبلش بالانتي اريزمياز لانه عندي very fast rhythm which is amiodarone already we talk about it. و ممكن نعطي السينكرونايز كارديو فيرجن مثل ما تكلمنا عنه. اوكي فاذا this is for the rhythm. Now we are going to give a case scenario. Do you have any question في اي شيء قبل ما نحكم على الكيس سيناريو؟ لازم وضحت هذا الريزم لانه اذا ما قدرتوا واذا ما وضحت بالنسبه لكم مش هتفهموا الكيس سيناريو كثير. Any question about this one? Excellent. Great. If there is no question فاذا give me 1 minute عشان غير السلايد. اوكي وكون مع الكيس سيناريو just to see how we could identify. اذا I need 1 minute to change the slide and I will be with the next session. Yes, أخ علي عم يقول there is risk of thrombus formation like yes there is risk مشان هيك عم نعطي الهيبارين أنتي ثرومبوليتيك أوكي فإذا there is you know risk على لأنه one of the leading cause هي الموضوعين atrial fibrillation و atrial flutter is the pulmonary embolism. اوكي رح نبتدي نكمل بنفس الموضوع and we are going to give like a case scenario now to see what we are going to do يعني رح نشوف مثل case scenario هيدي كمان quick review مثل ما تكلمنا this is a normal ECG that how the ECG should look for everyone كيف ال ECG بيكون يعني واضح للكل and this is a normal sinus rhythm كل الكومبوننتس موجودة وكل المقاييس موجودة سواء الهارت ريت أو الريزم أو البي ويف أو البي ار انترفال أو الكيو ار اس. طيب I want to show you something here. Please kindly can you interpret this rhythm هيدا الريزم اللي هنا كيف شو المشكل فيه شو can you interpret from the basic يعني بدي بلش معكم من البيزك. How would you interpret this rhythm؟ نحن دائما نتذكر بموضوع الاي سي جي نحن دائما we will refer to the pulse هل يا ترى البلس موجود ولا مش موجود هيدي أهم نقطة بالموضوع. I need always to interfere with the pulse. طيب here let's start with the basic. As in basic I need to see the basic. There is P here. Are you able to see a P here? I cannot see any P. Are you able to see a QRS? مش واضحة. Are you able to see a PT, PR, RR? As in all the components here of the rhythm are not available. In addition, when I took the pulse, there is no pulse. As in كل الكومبوننتس تبع الاي سي جي هون ولا وحدة منهم available. Plus there is no pulse. مثل ما تكلمنا بنرجع للبيزك انه نحن مثل مريض عنده مشكل ارتفاع بالضغط ارتفاع بالهارت ريت والى اخره it would be treated بس ما في يقول انه المريض he is going to pass away مش مريض هون he is in a life threatening condition بس اذا مريض there is no pulse وما في عنده blood pressure he is يعني mainly pass away هون كل الكومبوننتس not available plus there is no pulse this is we call it this case it required a shock بنسميها a ventricular fibrillation not the PA. This is a ventricular fibrillation VF. إذا هيدي this is we call it a shockable rhythm. طيب خلينا نشوف هون الريزم اللي حده. What we call the شو المشكل بهذا الريزم اللي هنا؟ This one. What is the problem here? من دائما نركز على ال. There is P. I cannot see it. There is a QRS maybe, but it seems that it's little wide. Yes. Here the QRS is RR. In addition, what shall I do here? إذا ما مبين عندي البي كيو ار اس اتس فيري وايد ما عندي proper identification of ECG بس what shall I do in addition مشان to confirmation شو لازم اسوي هنا؟ لا قبل ما اكلف اذا هون قبل ما احكي اي ما ببلش تريتمنت ولا ببلش اي شيء دائما بدي شيك على البالس هير I check the pulse, there is no pulse. فإذا هون بهودي التوريزم أنا I have here كل الكومبوننتس مش موجودة و there is no pulse. وهون كمان ال PR مش موجودة وال RR وال QRS it's white but كمان ما عندي pulse. This is I call it a pulseless VTEC. شو معناتها كلمة pulseless؟ وقت بقول كلمة pulseless يعني there is no pulse. اوكي بينما لو هون عندي هنا نفس الرزم and there is pulse it will be treated as what؟ إذا عندي نفس الرزم but there is pulse it will be treated as what؟ كيف تصنف؟ حتى أي كاتيجوري؟ it will be like a tachycardic rhythm مثل supraventricular atrial fibrillation لأنه في pulse يعني it will fall under the tachycardic rhythm. بس هون المشكل إنه there is no pulse. بهودي rhythm we call it a shockable rhythm. إذا إيش هن a rhythm that we call it a shockable rhythm? This is the pulseless VTAC and VF. Pulse there is no pulse. يعني ventricular fibrillation ما عندي rhythm والpulseless VTAC ما عندي rhythm. How the two rhythm we call it a shockable rhythm. ليش shockable؟ لأنه ما عندي rhythm ما عندي نبض بقلب المريض. I need to give a shock. طيب here how would you see the rhythm here؟ هيدي الصورة اللي هون اللي بنشوف flat. What we call this and how would you interpret it؟ here رح كمان نروح على البيزك. Okay, let me start with the basic as well. ليش asystole؟ Can I see the P؟ No. Can I see the QRS؟ No. Can I see the T؟ No. PR interval. طيب for me شو الفرق بين this one and this one؟ What are the difference between this one and this one؟ شو الفرق اثنيناتهم؟ it's meaning to going flat. Here two things. When I check a pulse هون دايما بقول لكم بعتمد على البلس. there is pulse بينما هون ما في pulse. الشغلة الثانية و very important إنه دايما ممكن المريض عنده هذا الريزم but he's awake conscious oriented ممكن يكون هو الليد فلتانين يعني مش مشكل بالليد يعني ما عنده أي اي سي جي بروبلم بس عنده مشكلة إنه الليد اتس disconnected لك يعطي هذا الشيء. هون what is the difference؟ فإذا the difference between these two here there is pulse here there is no pulse. هون ممكن يكون السبب انه ما يكون عنده اي مشكله but it's disconnected الليد تبعه. now فاذا always مثل ما شفتوا انه دائما انا I am referring to the pulse of the patient. مش اذا عنده pulse ولا. فاذا we call it here a non-shockable. اللي هو شو معناتها non-shockable؟ يعني هي rhythm does not require any shock. فاذا انت بعطي الشوك بحالتين بس ألا وهي الحالة الأولى الفنتريكولار فيبريشن والحالة الثانية ألا وهي ال PA or pulses electrical activities. وفي حالات بنسميها النون شوكابل اللي هي asystole وال PEA pulses electrical. شو يعني ال PEA؟ P pulseless E electrical A activity. شو معناتها ال PEA؟ What do you think in one word؟ إذا pulse there is no pulse يعني بتشوفوا رسمة there is no pulse. طيب إذا بما إنه شفناه هون رح فرجيكم صور الحين بدون نبض. اكسلنت. رح فرجيكم صور الحين تنشوف نحن what will be the line of treatment. هون رح ابلش مثل ما حكينا. فاذا لازم تتابعوا معي من الاول تنعرف كل وحده يعني ب what will be the treatment اللي هي البيزك تبع فاذا لازم نتابع مع كل وحده تنشوف what are the basic of the دواء. مثل ما شفنا في عنا الرزم ينقسم إلى شوكابل ألا وهو اليسار اللي هنا، والنون شوكابل اللي هو على سوري على بالنسبة يعني يمين. طيب إذا أول شغلة it's very important if you have a patient admitted for the emergency department with chest pain or hemodynamic whatever، بيجيكم مريض عنده chest pain dizziness أو يعني any complaint، it's very important to connect the patient to the monitor. ما بقدر اتصرف أنا مع مريض for example عنده chest pain or angina unless the patient is connected to the monitor. بده يكون connected على المونيتور. After the connection بيكون في عندي 4 category of rhythm، يا أما tachycardia or bradycardia already we spoke about it. ممكن يكون في عندي another two rhythm اللي هو الاسيستولي والبي اي اي already شفت الصور طبعا. Now إذا باخذ موضوع الاسيستولي and the PEA دايما very important to connect the patient to the monitor and you connect the patient to the monitor and you found there is asystole. شو نتصرف؟ What you will do؟ دغري CPR. You need to check first if really the lead it's connected well. مثلا أهم شيء أنا تشيك إنه الليد it's very connected well. شيكت إنه المريض the lead is connected. asystole line of treatment بالاسيستولي والبي اي الا وهي البالسس electrical activities يعني هن على ثلاث اشياء فاحفظوا نمبر 3 الا وهي CPR epinephrine and treat the cause which is 5H and 5T. إذا يعني عنده المريض نتيجة hypoxemia hypovolemia hypoxia hydrogen hyperkalemia or hypothermia tension pneumothorax tamponade cardiac toxin thrombosis or coronary. إذا هون بدي بلش أنا after connecting the patient to the monitor بين عنده إنه المريض he has a asystole. مثل ما حكينا دائما أهم شيء أنا شيك على البلس لأنه البلس هو أساس كل شيء. عنده asystole بدي شيك إنه it's really connected يعني على المونيتور yes or no. إذا شيكت إنه connected على المونيتور ما في أي مشكلة وبين إنه asystole اللاين اوف تريتمنت يقتصر على الشكل التالي مثل ما حكينا CPR and epinephrine and always we need to treat the cause. كيف مثل الابنفرين 1 ملغ every 2 to 5 minutes والسي بي ار يعني رح اشوفها بالشوكابل اللي هي ال5 cycles and 2. اوكي بس هون وقت بنحكي عن الاسيستولي we call it a non-shockable rhythm. طيب بنفوت بالأقام ألا وهي الشوكابل ريزم. ليش قلنا لها شوكابل ريزم؟ Why we call it a shockable rhythm؟ بعدنا عم نقول ليش سميناها شوكابل؟ لأنه simply there is no pulse. ما بين عندي pulse المريض. Connect to the monitor ومريض يعني ما راح بيكون مريض become unresponsive connected to the monitor and no. We will give a case scenario to see. You have a patient 54 years old. They brought him to the emergency department by ambulance and he is unresponsive. What to do? شو نسوي؟ Case scenario, you have a 54 years old brought by ambulance to the department of emergency and the patient he is unresponsive. What to do? شو نسوي معه؟ إذا أول شغلة patient he will be a coded patient. Coded يعني patient he need to go directly to the resuscitation room. أول شغلة patient and he will be coded. He will announce a code. طيب now when we announce the code يبقى يكون في عندي أنا الكود team. Yes كل طوارئ we have a كود تيم. مين مؤلف الكود تيم؟ من هن الأفراد الكود تيم؟ how many person and شو الرول تبع كل شخص؟ as an excellent as an I have a team leader اللي هو مسؤول عن التيم، وبيكون معه another person or other peoples اللي هن one responsible for medication يعطي الميديكيشن، one is responsible to look after the airway, one is responsible to provide CPR, and one is responsible to record everything. فإذا كل شخص بالتيم أو بالكود تيم يعني he has different role. وتنعطي الكود وننص الكود. Team leader is responsible to distribute them, to give them a task, and they will be report. يعني he's the one to correct them. مثل ما حكينا حدا على CPR، حدا for recording، حدا على الميديكيشن، and حدا على الايروي. Now مثلا اجى المريض عندي على الطوارئ، he is unresponsive. I put him in the resuscitation room. We announce a code. The code team announce he came and he start the resuscitation process. كيف بتبلش ال resuscitation process? From where I will start now? Everything is ready, team ready, and we connect him to the monitor. Or what will be the role of the team? شو بتبلش what are the resuscitation process here? مثلا here very important first of all to connect to the patient to the monitor. لأن أنا بدي أعرف I need to know what type of rhythm do I have. ضروري أعرف أنا شو هو نوع الريزم اللي موجود. فإذا what type of rhythm I am dealing with هون. فإذا first of all I need to connect the patient to the monitor. إذا صار عندي ال pulses VTAC or VF, this is an indication to give a shock. How many shock could we give? We could give up to 3 shock. but بيكون في عندي يعني pathway، بيكون في عندي يعني أشياء لازم سويها وقت الشوك. أول شغلة إذا first of all patient connected to the monitor we identified as pulses VTAC, we need to give a shock. First shock you will give a 200 joules. فإذا أهم شيء مثل ما حكينا شيك على البلس. There is no pulse I need to start CPR and giving. فإذا بنعطي الشوك which is 200 joule followed by what? Followed by CPR. CPR ألا وهي 5 cycles or 2 minutes. شو يعني ال 5 cycles؟ يعني كل cycle 1 2 3 4 5 6 7 8 9 10. 1 2 3 4 5 6 7 8 9 10. 1 2 3 4 5 6 7 8 9 10. بعطي 2 rescue breathing. فإذا هيك بلش 5 cycles 30 2 up to 2 minutes. شو بعمل بعد ما أعمل 5 cycles؟ What I will do after the 5 cycles 2 minutes I need to check the pulse again. فأنا أعطيت أول شوك وعملت 5 cycles of CPR 2 minutes، وبنفس الوقت كثير مهمة إنه what are the role of medication nurse. من أول شوك I will ask to prepare the epinephrine. epinephrine بينعطى 1 ملغ بس مش من أول شوك، من تاني شوك. يعني 1 ملغ every 2 to 3. medication nurse by default she needs to give 1 ملغ of epinephrine every 3 to 5 minutes. فإذا عملت أول cycle there is no pulse، بروح على second shock which is 300 joules. كمان shock given followed by 5 cycles 2 minutes. نفس sequences. After 5 cycles or 2 minutes I will check the pulse again. There is no pulse. نفس الوقت مثل ما حكينا الابنفرين is giving every 3 to 5 minutes. There is no pulse. شو بعمل؟ Again CPR 5 cycles 2 minutes. after the 5 cycles I need to check the pulse again. There is no pulse. بروح على ثالث شوك ألا وهي 360 جولز وبلش بالانتي اريزميا ميديكيشن ألا وهي الابنفرين 1 ملغ every 2 to 5 minutes والاميودارون 300 ملغ بولس second dose 150. فإذا هيدي هي السيكونسز أو this is how to approach a patient. إذا كتير مهم أعمل أنا identification للريزم. إذا ما قدرت عملت identification I cannot treat the patient. وكتير مهم أعرف شو هو الشوكبل والنون شوكبل. وقت بروح على الشوكبل يعني في عندي حط براسكم فيها 3 شوك 200 300 360 في عندي medication epinephrine anti arrhythmias والCPR. طيب what will be the expectation after the third shock؟ إيش هي expectation after the giving the third shock؟ فإذا نخلص أنا 3 shock what will be the expectation؟ already I finished 3 shock. Now what is the expectation؟ أعطيت الشوك. طيب كيف بده ينتهي عند الموضوع؟ I need to say now شو هي clinical outcome عند المريض if he is responding or not. if he is not responding هل يا ترى ممكن دل أنا forever أعطي شوك CPR؟ لا بساعتها نفوت بمرحلة do not resuscitate إلى آخره. بس ممكن المريض he might have a pulse and we will say that he is in a ROSC or return of spontaneous circulation. أوكي بتاعت المريض he will be transferred to ICU and you will avoid the hypothermia وإلى آخره. طيب this is وقت بنحكي هالكلمة أنا shockable والنون shockable. الشوكبل مثل ما حكينا البالسز في تاك والفي اف معناتها ما في بالس والنون shockable مثل الاسيستولي والبي اي. طيب now the same will be applied for the tachycardia. You have a patient admitted through the emergency department and with he's saying that I have like a palpitation. What you will do is the patient كمان فإذا جاكم مريض على الطوارئ and he has a tachycardia or palpitation. What you will do فإذا شو لازم نسوي؟ what to do here بهذا الموضوع كمان نفس الابروش مثل ما تكلمنا. we need to patient observe him, put him in a semi-sitting position, oxygenotherapy on oxygen, pulse oximeters, connecting to the monitor and to see how he is doing how hemodynamically he is doing. يعني هل يا ترى tachycardia and he is stable إذن كمان بكمل له under monitoring نطلب further investigation أو whatever, but very important to keep him under close observation till I make sure that everything is okay. Now if the patient he is unstable شو هي signs of instability like hypotension, decreased level of consciousness, and this is now I need to assess the QRS. Already we talk about it, which is mainly البيزك تبع ألا وهي السينكرونات كارديوفيرجن والميديكيشن تريتمنت بالادينوسين. يعني ما راح فوت كثير بعد بالتفاصيل جست تتعرفوا انه unstable tachycardia this is mainly synchronous cardioversion والادينوسين والى اخره. very important here patient stable under close observation, unstable intervention والميديكيشن تريتمنت مثل ما شفنا هون. يعني هي السينكرونايز كارديوفيرجن والميديكيشن تريتمنت. اي ريذم can you tell me few rhythm that they are يعني ممكن نعطفين ال synchronous cardioversion. Already we spoke like which rhythm نعطي فيها synchronous cardioversion like what? Give me example. كلمنا عنهم زي excellent. Supraventricular tachycardia, atrial fibrillation and atrial flutter. مثلا هودي الرزم اللي ممكن أنا أروح فيهم على السynchronized cardioversion. طيب. Here the same, I have a patient admitted through the emergency department and with bradycardia. You as the primary assessment, the triage, you find that the patient he has a bradycardia. What you will do now? شو لازم نتصرف مع المريض؟ Well, I need to hear from you. What you will do with this patient? Now, this is the same concept. نفس الشغلة. We need to قبل ما أروح قبل ما أعطي أي medication أي شيء I need to connect the patient to the monitor and to see if he is stable or unstable. If he is a stable patient, what you will do in case the patient is stable, put him under close observation. كمان براقب المريض لأنه if he is unstable ساعتها شو هن الأساس of instability? Hypotension, decreased level of consciousness, ischemic chest discomfort. ساعتها ببلش أنا اللاين اوف ثينك الا وهو الاتروبين dopamine epinephrine and we need to consider the consultant to يعني if he might need a pacing or pacemaker. فإذا كتير مهم هون الابروتش كتير مهم. مثل ما لاحظتوا انه دايما البيزك تبع هذا الموضوع كلياته هو شغلتين. هل البالس موجود او مش موجود؟ if he is the pulse is available ساعتها سواء كان تاكيكارديا شفنا شو التريتمنت الا وهو الاوبزرفيشن والسينكرونايز كارديوفيرجن والانتي اريزمز ميديكيشن والاميودرون. اذا البيشنت براديكارديا شفنا كمان نفس التريتمنت من حيث الميديكيشن يو ويل جو فور ذا اتروبين ومن ناحيه الانترفنشن ممكن نروح على الكارديو البيسنج. هونيك عندنا بالتاكيكارديا كارديوفيرجن، هون عندنا بيسنج، هون عندنا اتروبين، هونيك عندنا ابنفرين والانتي اريثمس. فاذا مثل ما لاحظتوا كل شيء وي هاف ا لاين اوف تريتمنت، بس دائما هو البالس. وقتها ما بيكون عندي بالس نهائيا خلص يعني انا بصير يعني بشكل. طيب مثل ما تكلمنا هي النقطة الأخيرة إنه بحال المريض suddenly after you deliver a shock 200 وعملته سي بي ار 300 و 360 he got a pulse. This is what we call a return of spontaneous circulation أو الروسك. إذا هون بنسميها الروسك of or return of spontaneous circulation. شو البيزك تبع الريتيرن؟ فإذا كثير مهمة أعرف what are the basic of the risk of return of spontaneous circulation. أول شغلة optimize the ventilation and oxygenation by maintain oxygenation saturation up to 94 and consider advanced airway and waveform capnography and do not hyper ventilate. ما بروح على المريض do not hyperventilate the patient. Treating the hypotension, very important to control the blood pressure by controlling the hypotension من خلال نعطي IV bolus, vasopressors, infusion, and always بنشوف a treating cause with 12 lead ECG. Follow the command. If the patient كثير مهمة إنه المريض to consider the induced hypothermia، ومعظم المريض after returning to ROSC where they will go يعني وين بيكون النكست destination للمرضى they will go to the CSICU أو لأنه بنبلش هون بمرحلة يعني الريبرفيوجن كورونال ريبرفيوجن يا اما من خلال الستيمي او من خلال يعني البالون او الانترفنشن والى اخره. فاذا this is the pathway that the patient needs to follow. هون if the patient after the shock, after the cold, he return of spontaneous circulation, very important that the patient to مثل ما حكينا to not hyperventilate, no hyper to control the temperature, to avoid the hypotension, to avoid the hypothermia, to perfuse the patient and to transfer the patient to the cardiac ICU to be under close observation. And the doctor يعني for لأنه ما بينتهي الموضوع هون, the patient later he needs to decide what will be the next line of intervention or line of treatment, أو من خلال الانترفنشن مثل ما حكينا أو البالون أو you know وإلى آخره. So this is all what we need to know. بيكون عندنا هلا يعني بعد ما خلصنا طبعا في عندنا few rhythm, بس أنا أعطيتكم الرhythm الأساسية that you will need it on your practice on a daily basis. But plus اللي بعد عندنا موضوع البلوك اللي هو كثير how to treat a patient with block. رح نطلع على موضوع البيسنج بشكل كثير يعني نتكلم عنه. أنا شريت على قصة الكارديوفيرجن والشوك. بعد فينا موضوع البيسنج إن شاء الله مع النكست سبيكر بعد الظهر حيكون. But so far, this is what you need to know how to run a code, what are the elements of the code, and you know, what are the shockable, non-shockable, how to treat tachycardiac rhythm, how to treat bradycardiac rhythm. Do you have any question to ask me? في أي سؤال إن شاء الله الأشياء تكون واضحة. I wish that everything is clear for you. If you have any question, I'm ready to answer you now. أي سؤال, please ask me. And I'm ready to answer you before going for the lunch break and come back at the 1 o'clock inshallah. If you have any question, I will open the floor for more questions before ending. Yes, 3 shock. يلا عم نحكي. يعني 3 shock 2 minutes of CR in between. 200 CPR 5 cycles per minute. 300 CPR 360 دائما مثل ما تكلمنا. 3 shock ما في نعطي أكثر من 3 shock. و CPR in between 5 cycles or 2 minutes. Exactly. epinephrine every 3 to 5 minutes. بالأول shock you will prepare دائما the medication nurse كل 3 to 5 minutes she is the one to record and to give the epinephrine. كل 3 to 5 minutes. Every 3 to 5 minutes she needs to give the epinephrine. طيب. Thank you for your time. This is the time for go for break. يعطيكم ألف عافية and we will see you فإذا بعد في two important على الجنكشنال والبلوك. It will be given by one of our speakers in the afternoon. Okay, thank you for the attendance and see you inshallah at 1 o'clock.
السلام عليكم. في صوت. Can you hear me? Yes, good. And you can see the slide, which starts with junctional arrhythmias. سلايد موجود واضح؟ اوكي طيب ممتاز جدا. طيب welcome back to the last part of the presentations today, which is the junctional arrhythmias and blocks. So we will go over these two arrhythmias, and at the end we will just talk about what are the treatment options for blocks. So we'll just cover a little bit about pacing. All right. طيب أنا أشوف إنه يعني تقريبا العدد كويس فنقدر نبدأ صح؟ أوكي بسم الله. طيب when we talk about junctional rhythms اللي احنا we understand from the morning introduction anatomy and physiology and sinus and other arrhythmias that the where does the P wave has been born is where we name the rhythm. So if the P wave is born in the junction, then we call it junctional rhythm, or we call it junctional P wave. When we talk about junction, what do we mean by junction? We mean about the AV node and the bundle of His. And it is the area between the atria and the ventricle. هلا would you like to have some explanation in Arabic؟ تحبوا نوضح شوي بالعربي ولا English only is good؟ English only. Okay. Right. Some people they like some like Arabic explanation. It's fine. Okay. So we mean about the junction is the point, which is the AV node and the bundle of His. Okay, the bundle of His. فهي المنطقة اللي في المنتصف ما بين البطين والأذين. Okay. طبعا we know that after that we have the right, left bundle and we have the right bundle where they come from there. So if SA node is not working as a pacemaker, then AV node will become our secondary pacemaker because we are backed up by two levels of pacer in addition to the SA node. We know that we are backed up by AV node and we are backed up by the Purkinje fibers. So the AV node will make the junctional and the Purkinje fibers will make the ventricular and the interventricular pacing. Now, if the pacer of that P wave is meant to be the junction, the P wave will always travel against the normal direction of electricity. We know in the sinus rhythm, the P wave travels from SA node to AV node, then to Purkinje fibers. So the direction of the P wave will always follow the direction of the QRS. But in junctional rhythms, the P wave travels from down up to cover the atria and travel from up down, which is a normal direction for ECG, electric conduction, to cover the QRS. So the P wave will be inverted. If it comes before the QRS, we call it inverted or negative P wave. So if you imagine that the AV node is in the middle of the atria and ventricle, it fires upward, P wave will appear before the QRS. Okay, and you will notice that there is always an isoelectric phase before the Q, and there is an isoelectric phase after the S, if it happened after the QRS. So we are talking about this. This is the S, or the end of the S. So there is an isoelectric phase, then the P wave appears here as negative. So we have to agree on three major things. Number one, in junctional rhythms, the source of the P wave is the junction. So the P wave is negative. Okay? So this is the first thing. The source of the P wave is the junction. The second thing, that P wave is negative. And the third thing we should agree on is that the P wave will appear on three different locations. It might come before the QRS, and you will see it negative before. It might come within the QRS, and you will not see the P wave. And it might come after the QRS. You will see it after the S. Okay? So the R is always narrow, normal QRS, because the direction of electricity is normal. But the P wave location is going to be before, during, or after. And the P wave shape is always negative, okay? Is always negative. So the P wave is always down, So this is the nature of the junctional paced wave. Now, sometimes the AV node become an irritable point while the SA node is working. So what does that mean? There will be an ectopic beat marked, okay? There will be an ectopic beat marked from the junction during a sinus rhythm. And this is what we call it ectopy, or we call it premature junctional contraction. How does that look like? If you look at the curve here, or what we call it the QRS, in this, you have a narrow QRS, you have a T wave, followed by a new complex of PQRS, then a PQRS, then a PQRS, and you notice here there is a QRS that comes earlier. If you compare the distance here, you have 1, 2, 3 large boxes, while here the space is less than 3 boxes. It is 2 boxes and 1 small. So this is an early conduction. Okay, this is an early QRS. Now, if you look at the characteristics of this new QRS, the P wave is here, and the P wave is inverted. If you look at this P wave is normal. It's up. So this is a sinus P wave, while this one is an inverted P wave. So this P wave is negative. Okay, this P wave is negative, and the QRS is normal. So this is what we call it premature junctional contraction. It's a premature contraction, which means it's a QRS that happened earlier than it's supposed to be. Second, the nature of that conduction, because the P wave is inverted here, is a junctional pacer. So the pacemaker, or the firing of this QRS, did happen from the junction, not from the SA node. Okay? Now, if you complete the rhythm, you have here a PQRS T, a PQRS T, a PQRS T, a PQRS T, a PQRS T. So this is simply, if you count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, the rate is 110. The PR interval is normal. The QRS is narrow, except for this abnormally conducted QRS. It's a narrow QRS with an inverted P wave. So we call this rhythm sinus tachycardia with a premature junctional conduction. So this is a premature junctional conduction. So what do you mean by a premature? It's an early QRS has been stimulated from the AV node. And how did we know that it's from the AV node? Because the P wave of this QRS is inverted before the QRS. Okay. طيب, if we look at a different shape of this, we will look at this rhythm. Okay. Here you have 1, 2, 3, 4, 5, 6. Rate is 60. There is a P wave followed by a narrow QRS, then a T wave, then a P wave followed by a narrow QRS, then a T wave, and here I have an early QRS. For this QRS, if I'm going to analyze it, the size of the QRS here is similar to the size of the QRS here. And if I measure it in small squares, I have 1 and 2 small squares. Then this measures 0.08. It's normal because it is less than 0.12. And I will observe that I have an S here and I have a T wave here. And between the S and T, I have an inverted wave here. This inverted wave is not ST depression. It is a negative atrial conduction. So this is a sinus rhythm with a premature junctional conduction. Again, this is a PJC, but the P wave in this rhythm appear after the QRS. Okay, so if I will refer to the first understanding, which is this one, here I am marking my QRS is normal, but the conduction happened after the QRS. Okay, so if I will analyze it again, so the AV node is in the middle and the P wave comes after the QRS. Okay, so this is a normal, this is a sinus rhythm with a PJC. If you go here, you have a PQRST, this is normal, a PQRST normal, but again, I have an early conduction here, an early QRS followed by a negative P wave. So this is a second PJC. This is second PJC. Okay, so this is sinus rhythm with PJC, with a PJC. The ratio of normal to PJC is 2 to 1. So we call it junctional trigeminy. Okay, we call it junctional trigeminy because the third from tri is coming from 3. So that's why if every 2 normal, the third one is junctional premature conduction, we call it junctional trigeminy. Junctional trigeminy. What can cause a junctional premature conduction is electrolyte imbalance like hypocalcemia, hypomagnesemia, hypokalemia can lead to the early conductions. Okay, so that's why the treatment would be correct electrolytes. Okay, and if it is frequently recurrent and it is affecting the patient, you might give some antiarrhythmic medications. Is it clear to how to recognize a junctional premature out of a sinus rhythm? واضح؟ Clear. Okay, so you have a, it's if I want to simplify it, okay, I have a sinus rhythm here, sinus rhythm, but I have an early QRS. This QRS comes here. Like if you want to measure it from here to here, the distance, if I will count it, I have like 1, 2, 3, 4 large boxes. Okay, so if I will say 4 large boxes, the QRS must happen here. So this one comes earlier. And since it comes earlier, it's a premature conduction. I need to look what is the cause of that prematurity. Is it an atrial? If atrial, you will see an atrial P wave here. If it is ventricular, you will see a wide QRS here. And since it is a narrow QRS and there is no P wave between the T and the QRS, the P wave appears here or appears here. So that's a junctional P wave. Okay. And how to analyze it? This is the AV node, and the AV node here is conducting after the QRS. Okay. Why? This is a good question, Ali. Why sometimes before or under or after. This is the nature of the conduction. If the speed of the P wave is within the normal speed of natural conduction, it's gonna happen before the QRS. If it is equal to the QRS conduction time, it will be within the QRS, so you will not see it. And if the depolarization of the P wave that occur because of the junction is slower than the QRS, then it will appear after the QRS. It depends how long does it take for this depolarization stimulated by the junction to happen. Remember, it is an electric activity. Okay, it is electric activity. It can synchronize with the atrial function, and it might not synchronize with the atrial function. If it is synchronized with the atrial function, it will appear before the QRS, like this one. Okay, so like this one, it appears before the QRS because the speed of this depolarization, okay, the speed of depolarization happened before the QRS, which is, that's why it appear before the QRS. But here, the speed of atrial repolarization that is stimulated by the AV node was slower than the conduction of the QRS. That's why it appeared after the QRS as an activity. That's the reason why they can come before, during, or after. It depends on the speed of that conduction. If the AV node is the permanent pacemaker, which means the SA node is no more functioning. Okay, and our pacemaker is the AV node, then our pacemaker will become junction. Now, the nature of this, okay, QRSs are narrow. This is one. Second, R to R is regular. Okay. So first, QRSs are narrow. Second, R to R is always regular. Third, P wave will be inverted before, during, or after the QRS. Now, how do we classify it to junctional, accelerated junctional, or junctional tachycardia? It will depend on the rate. So I have a narrow complex, R to R is regular, P wave is inverted, or I cannot see it, or it comes after the QRS, but my rate is less than 60, we call it junctional rhythm. 1, 2, 3, 4, 5. Here the rate is 50. The QRS R to R is regular. P wave is inverted before the QRS. Here it's very obvious, okay? The P wave is inverted after the QRS, and the wave after the QRS immediately is the T wave. So this is junctional rhythm. This is a bradyrhythm, and it's gonna be treated like bradycardia. It needs atropine, it needs epinephrine or dopamine infusion, it might require transcutaneous pacemaker, okay? So this is very simple, very clear. How do we recognize junctional? Okay, narrow QRS, R to R is regular, but P wave is inverted before, or if I cannot see the P wave and the QRS is narrow, this is also junctional. Okay, rate is between 40 to 60, or in general less than 60, we call it junctional rhythm. And if it is symptomatic, yani we have symptoms of decreased cardiac output, pulse is weak, blood pressure is low, patient is confused, skin is cold, then this one has to be treated like bradycardia, which is atropine and dopamine or epinephrine infusion and pacemaker. Now, the junctional rhythm can be faster than normal, okay? But the nature and the characteristic of the rhythm as a junctional will never change. As we agreed, the QRS is narrow. The R to R is regular. the P wave should appear before, during, or after. In this rhythm, let us apply the rules. 1, 2, 3, 4, 5, 6, 7, 8, 9. The rate is 90. So this rate is between 60 to 100. Okay? Second, the QRSs are narrow QRSs. They are normal. Look at the P wave. I have a T wave, but I cannot identify a P wave. There is no P wave here at all. Where is the P wave? Because the QRS is narrow, it is junctional. If the QRS is wide, that will go edgeventricular. So in a narrow QRS that I cannot see the P wave neither before nor after the QRS, I will assume that the P wave is hidden here, okay, in between the two, within the QRS, because this is the nature of the junctional. We call this accelerated junctional rhythm. We call this accelerated junctional rhythm. If this rhythm is symptomatic, the best treatment, okay, for accelerated junctional rhythms, if the rate is less than 100, we might speed it up with atropine. We might use epinephrine that will help to gain back the sinus rhythm. And if it did not respond and become symptomatic, we might use pacemaker, okay? We might use pacemaker. So again, this is regular R2R, rate is 90, the QRS is narrow, the T wave is normal, but I cannot see the P wave. So here, the correlation will come based on wide or narrow QRSs. The wide QRSs, we call them edgeventricular, but this is narrow. Since it is narrow, we call it junctional, okay? We call it junctional. So this is accelerated junctional rhythm, accelerated junctional rhythm. Also, junctional rhythm can go higher than 100. 101 can reach up to 180, okay? In this case, I will identify the rhythm as 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. The rate is 110. This is tachycardia. The QRSs are narrow. All of them are narrow QRSs, normal. Second, R2R is regular. So this is 3. The last thing I will look at is the P wave. Before the QRSs, I see no P wave. But if I will look here, I can identify QRS. QRS, but after the S, and the S is completely formed, okay? As you see, it comes back and makes an isoelectric line here. There is a wave between the T wave and the S. This wave is inverted. So this wave is the junctional inverted P wave that comes after the QRS. Okay, so because if I will isolate the QRS, I can say QRS alone. Okay, I can see QRS alone, and this is the P wave here. Okay, this is not ST depression. The ST depression, the S is not gonna go up. The S will come down. This is a negative P wave. This is a negative P wave after the QRS. Okay, so this is how we segregate or distinguish between junctional rhythm. The P wave comes after the QRS, okay, is by having the S complete up to this point, okay? And the T wave supposed to start from here if the line is straight, but I have a P wave here in between. So we call this junctional tachycardia, okay? Again, rate is 110, R2R is regular, QRSs are normal, T waves are normal. The only abnormality here I can see that S is complete, because if you will just forget about this line here, you have a complete QRS. P QRS is 100% complete up to here, and this is part of the ST segment, but here the T is up, so I cannot say ST depression. This is a P wave after the QRS. So this is the nature of the junctional wave that comes after the T wave. It is tachycardia because the rate is higher than 100. And it is junctional because the QRS is narrow and the P wave is after the T wave. Okay, clear? How do we treat it? In majority of time, if we decrease the rate, you might get an SA node to come back. But if SA node did not come back, this rhythm will require always a transcutaneous spacer. Okay, this rhythm will require a transcutaneous pacing. So what are the causes of junctional tachycardia? Myocardial ischemia or infarct, congestive heart failure, and digitalis toxicity. Are we clear with the junctional? If junctional is clear, we can move to the next topic, which is AV blocks. If you have any question, you can ask about junctional before we move to the next topic. Okay. Thank you, Yani. Okay. طيب. First degree AV block. Now we want to understand what do we mean by a block. The block means the P wave always happen in the SA node, and the P wave will go through the atria, and then it will pass through the AV node in order to reach down to the ventricles. Okay? Now, when there is any delay in the AV node and the junction, that is gonna show an abnormal time between P wave and QRS, between P wave and the QRS. This will be represented in delay of the PR interval or abnormal PR relation, okay? Abnormal PR relation. So simply, the heart block is a delay of conducting the P wave that happen in the SA node down to the ventricles. Okay, so it is represented by an abnormal P to R relation. Okay. If I will look at this rhythm, I will count the rate 1, 2, 3, 4, 5, 6. Rate is 60. So this rate is normal. The QRS is regular. R to R is regular. The QRS is normal as a QRS, and I have a normal T wave. But if I look at the PR interval, and how do we measure the PR interval? From the beginning of the P wave to the end of the PR segment, so beginning of the Q. Now, if I will apply the numbers here, I will count 1, 2, 3, 4, 5, 6, 7, 8 small squares. Okay, so this is 8 small squares, 8 مربعات صغيرة. Okay, طيب 8 multiplied by 0.04 is 0.36. So we all know that the normal PR interval is 0.12 to 0.20. So if I will translate this language to small squares, it should not exceed a large square. It should not exceed 5 squares, 5 smalls. So if this is normal, the P should end here, but I have an extended, a prolonged PR interval. Okay, so I have narrow QRS, regular R to R, rate is normal, T wave is normal, P wave is sinus because it's positive of before the QRS, and every P wave has only one QRS after that. That's why we call it sinus rhythm. Why do we call it sinus rhythm? Because the P wave is sinus. But we call it sinus rhythm with first degree AV block because the PR interval is longer than 0.20. It's longer than large square, small, large, big, large square, or longer than 5 small squares. That is the first degree AV block. So the first degree AV block is the first level of a heart block or the AV block. It's a slowness in the conduction. The conduction becomes slow, but still every P wave is reaching down and get conducted without any block. Okay, so the first degree AV block, there is no actual block to the AV node, but there is a delay in the PR interval. Okay, so every P wave reach down and get conducted because this is what we are looking for. I want every, can you answer me please? This is for what? This is for the CME. This question is, see, everyone, if you are registered now here, sorry to interrupt the presentation, I need just to answer, but I am expecting maybe the control will answer you. As long as you are now registered, you are already registered to the workshop. And CME and certificate are gonna be emailed to every one of you. Don't worry. Your name is already registered because you are already signed in to the workshop. Is it clear? Don't worry about it. No, don't, please, if you are registered, your name appear here, you are part of the presentation, you are automatically registered to the workshop. And all of you, you will get the CME hours with the certificate. So don't worry about that. Okay, just focus with the class. Thank you very much. I know that all of you need the CMEs, but you will get it 100% sure. Okay, طيب, let's get back to the block. Okay. طيب, let's get back to the presentation. Okay. After this, the control is gonna answer you, or they will send. You can send your questions through the WhatsApp. Okay. If you have any question, please send it to the same WhatsApp that you registered through. Let us focus on the class. Okay. Thank you very much. So the first degree, as we said, there is a delay in the PR interval, but every P wave has only one QRS. We call this first degree AV block, or we prefer to call it sinus rhythm with first degree AV block. Usually, the first degree AV block is asymptomatic. We don't need to interfere unless the rate is brady and becomes symptomatic. If the rate is brady, yani less than 60 and or symptomatic, then what do we need to do? We need to give the patient atropine, and we will connect the patient to temporary pacer. We will connect patient to temporary pacer, and we have to call the cardiologist to evaluate the patients. If this is a permanent problem, then the patient might require to have a permanent pacing, okay? But usually permanent pacing doesn't happen in 1 hour, but we have the transcutaneous pacer that is followed by an intravenous pacer. And then if the patient requires to have an implanted pacemaker, they will decide upon that, okay? So as we said, the first degree AV block is a 1 P wave followed by a QRS without any extra P waves. So atrial rate, which is the P waves, and ventricular rate, which is the QRSs, are the same. R to R is regular. QRSs are narrow. P waves are sinus. The only abnormality is PR interval is longer than 5 small squares, or it is longer than 0.20 seconds. So, okay, so the prolongation of the PR interval is the main characteristic of a sinus rhythm with first degree AV block. Okay, but we need to closely observe the patient to find what are the reasons. It can be caused by ischemia, can be caused by digitalis toxicity, can be caused by any antiarrhythmic medication, but we have to closely monitor the patient. Okay. Now, the AV block can get worse. And how it can get worsened? It can get worsened by developing from first degree to second degree. And the second degree AV block is composed of 3 different types. We have second degree type 1, second degree type 2, and second degree 2 to 1. Let's focus on this rhythm. Now, if I will calculate the rate 1, 2, 3, 4, 5, 6, okay, the rate is 60, okay? Now, if you will look at the P wave, the QRSs, all the QRSs are normal QRSs. They are narrow QRSs. Now, if you look at the P wave, you will observe that this P wave, which I marked with an arrow here, has a PR interval that is short. If you look at the second PR interval, it gets longer. If you look at the third PR interval, it gets more longer than the second one and the third one and the first one. What do we call this? We call this progressive prolongation of PR interval. Okay? Progressive prolongation of a PR interval. But every P wave is followed by a QRS. Okay? Every P wave is followed by a QRS. So this is a short QRS, longer QRS, more longer QRS. And if you go here, you will see a P wave that is not followed by a QRS. Okay? So this is the second degree type 1 phenomena. It's a progressive prolongation of PR interval until a QRS is dropped or until a P wave non-conducted. Okay, so it's either we say a dropped QRS or an unconducted P wave. Okay, an unconducted P wave. Okay, again, PR intervals start to become short, longer, a P wave not followed by a QRS. Now, we all know that this is a phenomena, okay, that repeat itself as a cycle. That's we call it cyclic phenomena. What does cyclic phenomena? If you look here, after the block, what happened? A QRS has been conducted with a short PR interval that become prolonged here, then longer here, and if I have enough time in the strip, I will see a P wave that is not followed by a QRS. Okay, so second degree type 2, progressive prolongation of PR interval until an unconducted P wave or a dropped QRS, and it is a cycle that repeats itself. So this cycle is similar to this cycle. That's why it's a cyclic phenomena. It's a cyclic phenomena. Do you have any question on second degree type 2? Second degree type 2 is worse than second degree type 1 because there is always a high tendency that second degree type 2 become a third degree AV block. The treatment here is atropine or epinephrine dopamine infusion, and you need to make sure that patient is connected to transcutaneous pacemaker, okay? طيب. Now, so second degree type 1 was a cyclic phenomena. Cyclic, short, long, longer, drop. In the second degree type 2, you will see two phenomena or phenomenon. Every P wave is either conducted or non-conducted. Okay, so conducted means followed by a QRS, or a P wave that is not followed by any QRS. If you will go here, 1, 2, 3, 4, rate is low, and the QRS is wide as a nature. Okay, now P wave, it can be wide or narrow QRS. It depends. Okay, and every P wave here is followed by a QRS, and you have a P wave that is not followed by a QRS. So this is the second degree type 2. Okay, don't mix between second degree type 2 and third degree, because in the second degree type 2, the relationship between the P and the QRS is very clear. All PR intervals are the same. And if you notice something, P to P is always regular. Okay, so the distance between P wave, the next P wave, the next P wave, the next P wave, the next P wave, and the next P wave are all regular. So all P waves comes at the same rate. But some of them are conducted, yani they could pass the AV node to create a QRS, and some of them fail to cross the AV node to become a QRS. Okay, now the best treatment for second degree type 2 is atropine, epinephrine. Okay, atropine, epinephrine, dopamine infusion, and transcutaneous pacer. Okay, so how do we differentiate between second degree type 2 and second degree type 1? Type 1, progressive prolongation. A QRS is dropped here. In second degree type 2, all PR intervals are fixed. Okay, now we agreed that the heart block is the relationship between the P wave and the QRS. So in the second degree type 2, the rate is low. The P to QRS in the conducted P waves is almost always the same, but I have P wave that has been blocked at the AV node. Okay, so majority of patient with second degree type 2 requires pacing. Okay, requires pacing. So you need always to make sure that transcutaneous pacer is around, but quickly you can give your patient atropine or start infusion until the cardiologist will evaluate the patient and they will assess the need for a permanent pacemaker. Okay, or at least intravenous pacemaker, unless the patient situation is cleared. Okay. Again, what is this rhythm? Can anybody answer? Second degree type 2. Yes, it is second degree type 2. Excellent. Now, if you look at this rhythm, the second degree 2 to 1, what you will notice? You will notice here there is a P wave, followed by a P wave, followed by a QRS. A P wave, followed by a P wave, followed by a QRS. P wave, QRS, P wave, QRS. Now, R to R is regular, okay? 1, 2, 3, 4. Ventricular rate is 40. So the ventricular rate is 40 to 50. 40 to 50. So it's a brady. Atrial rate is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Atrial rate is 100. Okay, so atrial rate is 100, ventricular rate is 50. So what is the relationship between, or the ratio of atrial rate to ventricular rate? It is 2 to 1. I have 100 atrial conduction to 50 ventricular conduction. So this is a 2 to 1 ratio. Okay, now I have a P wave that has been conducted, followed by a QRS, and a P wave that is not conducted. Okay, a P wave that is not conducted. So this is a 2 to 1 ratio. So every 2 P waves. So the nature of the P wave is a sinus P wave because it's a small, positive, rounded, and before the QRS. Small, positive, rounded before the QRS. If you look at the PR interval here, the PR intervals in the 2 to 1 conduction is the same, okay? If you will measure it, 1, 2, 3, 4, 5 small squares. So this is a normal PR interval, normal PR interval, and here you have a normal PR interval, a normal PR interval. So all the conducted P waves, they are normal PR interval, but here you have 1, 2, 3, 4, 5 P waves that are not followed by a QRS. Okay, so that's why we call this block second degree type 2 to 1, or we call it 2 to 1 AV block. We call it 2 to 1 AV block. Actually, it falls under the second degree. Okay, it falls under the second degree AV blocks. So this is as we we always make a joke. We say it's a man who is married to 2 wives. Okay, رجل وحرمتين. Okay, هذا رجل وحريمه الاثنتان. يعني الرجال متزوج حرمتين. It's a husband and 2 wives. So that's why we call it 2 P waves followed by 1 QRS. The treatment for this is similar like any other AV blocks. You need atropine, dopamine, epinephrine infusion, and you need to conduct or connect patient to the transcutaneous spacer, and you need to call the cardiologist to evaluate, okay, to evaluate. Also, this person might require an intravenous pacemaker, okay, and he will be evaluated for the need of permanent pacemaker. The complete AV block. The complete AV block is also known as a third degree. Is also known as a third degree AV block. Now, a secondary pacemaker, either junctional or ventricular, stimulate the ventricle. So you might see a wide QRS or a narrow QRS because the AV node and the SA node and the ventricles are dissociated. What do you mean by dissociated? You will see that P wave are conducted at a regular fashion. Okay, you see this is a P wave, second P wave, third P wave, fourth P wave, fifth P wave, sixth P wave, seventh, 8, 9. So if you go 1, 2, 3, 4, 5, 6, 7, 8, 9, the atrial rate is 90. 1, 2, 3, 4, 5, the ventricular rate is 50. Okay, so that's why atrial rate is 90, ventricular rate is 50. P wave to P wave is regular. QRS to QRS is regular. But P wave to QRS has no relation. Why do we say no relation? Because the P wave here happens, that is not followed by a QRS. This one is far away. This one comes after the T wave. And there is a P wave that happened here within the QRS. Because if you look at the shape of the QRS here, and you compare it to the QRS here, the conductivity here has more positive charge because this one is higher as a volt, okay? Same thing is happening here, okay? Same thing is happening here. So this is what we call it complete heart block. Again, let's look at the next rhythm here. You have P wave, P wave, P wave, P wave, and there is a P wave also here comes within the QRS, a P wave here after the T wave, and a P wave here, and definitely there is a P wave here. So if you go 1, 2, 3, 4, 5, 6, 7, 8, atrial rate is 80. If you go 1, 2, 3, ventricular rate is 30. Okay, ventricular rate is 30. And the PR interval has no relation because look, where is the P wave here? Look, where is the P wave here? The P wave here is before the QRS, and the second P wave here is happening exactly after the T wave. So that's what do we mean by no relationship between the atria, which is represented by the T wave, and the ventricle, which is represented by the QRS, because the AV node is not allowing any of the P waves to be conducted, okay? Any of the P waves to be conducted. What is the difference between third degree AV block and second degree AV block type 2? If we will go back to the type 2, P wave here to QRS is fixed. So there is a relationship, and I don't see any P waves in the middle. Yes, this is a blocked P wave. This is a blocked P wave, but this is a conducted P wave. This is a conducted P wave. If you will go to second degree type 1, the PR interval is clear because here you have a P wave followed by a QRS, but PR interval is short. It's getting longer, and the P wave here is not followed by a QRS. It is repeating itself here. A P wave is short, longer, but in the third degree AV block, okay, the P wave here has no relation. Because where is the P wave here? I don't see it. Where is the P wave here? If this one is different as the distance from this one. So here, it is getting shorter, not longer. So there is no relationship between the P wave and the QRS. Okay? So this is how we differentiate between third degree and other conductions. Okay? So to analyze the rhythm again, 1, 2, 3, 4, 5, ventricular rate is 50, R to R is regular, P wave to P wave is regular, but P to QRS is not the same, It has no pattern, okay? ما إلها نمط ثابت إطلاقا، تيجي عشوائية. Once you see or identify that the P wave is getting through the QRS or through a T wave, then definitely you will know that this is a third degree or a complete AV block. So atria is firing alone. The ventricles are paced from either a junction or ventricular pacemaker, and they are not talking to each other. There is no relation. There is no correlation between first degree, between the P wave and the QRS in the third degree AV block. Okay? So as you see here, R to R is regular, P wave to P wave is regular, but the PR interval is not initiated at all, because there is no point that you have a P wave here followed by a P wave here and they don't have a relation. طيب. Someone will ask me a question. I have 1, 2 P waves, then a QRS. 1, 2 P wave, then a QRS. 1, 2 P wave and a QRS. Okay? طيب. What is the difference between this one and this one? Here, the P to QRS is fixed. Can you see the PR interval? It's very clear. Okay? The P wave to P wave are the same distance, and the P to QRS has the same distance. But if you go to the third degree AV block, P wave to P wave are at the same distance, but the P wave to the QRS, there is no distance. Here, the P wave comes fused or at the same of the T wave. Here, the P wave comes within the QRS itself, okay? Within the QRS itself. So this is how we distinguish between first degree and between third degree AV block and other types of a block, okay? So let me go back again from the beginning to identify the block. Now we said the block is a delay or abnormal conduction of SA node through AV node. So which means the AV block is the disease of the AV node. Okay, the disease of the AV node. Which patients might have a heart block? A patient with septal MI. Okay, any patient has septal MI, okay, is a high risk of AV block. And how do we recognize the septal MI? There is ST depression on V1 and V2, which are the first two chest leads, okay? The first two chest leads. So you will see an ST depression or ST elevation in these two leads. This is one, ST elevation, okay? Second, okay, patient post mitral valve or aortic valve or tricuspid valve or pulmonic valve surgery, okay? Pediatric with post heart anomaly surgery, someone with ASD or VSD or tetralogy of Fallot, okay? Those people, they have a surgery where the septum is included, they might develop, okay, AV block. Patient post electric physiological study, those who have ablation, اللي يتعرضوا على عمليات كوي الابنورمال conduction في الهارت في الكاث لاب. So post cath lab, for certain procedure, the patient might develop heart block. Okay, so ischemia, intracardiac surgery, septal, like atrial septal or ventricular septal, or valve replacement surgeries, and post-ablation, okay? In the electrophysiological study in the cath lab, the patient might develop heart block, okay? Might develop heart block. The heart block patients always require to make sure that we have a pacemaker. We have a pacemaker, okay? طيب. So the first degree AV block is a sinus rhythm, and it is sinus because P wave is sinus. QRS is narrow. R to R is regular. Atrial rate is equal to ventricular rate. I have 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. So atrial rate, ventricular rate are the same, but my PR interval is longer than 0.20 second. Okay, so this is the first degree AV block. The second degree AV block type 1 is the R to R is regular, 1, 2, 3, 4, 5, 6. This is the exception here. R to R is not regular. So in second degree type 1 and second degree type 2, R to R are not regular. Okay, R to R is not regular. So I have 4 AV blocks. Type 1, 2 to 1, and third degree AV block R to R are regular. In second degree type 1, second degree type 2, R to R are irregular. Okay, are irregular. And at the same time, 1, 2, 3, 4, 5, 6, 7, 1, 2, 3, 4, 5, 6. Atrial rate is higher than ventricular rate in second degree type 1. And in second degree type 2, okay, second degree type 1, second degree type 2, second degree 2 to 1, third degree atrial rate is higher than ventricular rate. I mean, I have more P waves than QRSs. Okay? So here it is irregular because here I don't have R happening. So short, long, longer, progressive prolongation until I have a missing QRS after a P wave. So this P wave has been blocked at the AV node. So this one was conducted, this one was conducted, but slower. This one is more slower, and a QRS has been missing here. Okay? Again, it's a cyclic phenomena, short, long, longer, and definitely there is a drop here. So this is the second degree type 1. Second degree type 2, also it is irregular. QRS might be narrow or wide. It depends on the pacemaker. P wave is sinus. In conducted P waves, P wave to QRS, which is the PR interval, is fixed, and you have a P waves that are not conducted. It's dangerous. شوية عربي. اوكي يا نهى، شوية عربي. ارجع من اول. احنا نقول بالنسبة للانسداد الاذيني، هذا نسميه اوكي، انسداد العقدة الاذينية. شكرا انك طلبتي، لانه انا عرضت في البداية. اوكي، انا عرضت في البداية قلت اتكلم عربي، اعطوني ناس انه انجليزي. اوكي، فشكرا انك سألتي. ففي الانسداد في الانسداد العقد الأذينية تصير في عندي بطء في إنه التيار الكهربائي يوصل من الأذين للبطين. أوكي، فتنقسم العملية ل5 أنواع. طبعا هنسميها درجات الانسداد اللي هي degrees of a block. أوكي، فأنا عندي المسافة الطبيعية للتيار الكهربائي أو التوصيل الكهربائي عشان يوصل من الأذين للبطين غالبا هو عبارة عن 3 إلى 5 مربعات صغيرة. زمن المربع الصغير 0.04 سكند. أوكي، 4 أعشار 4% من الثانية. أوكي، 4% من الثانية. فأنا كيف أعرف قديش الزمن؟ أضرب عدد المربعات الصغيرة بزمن المربع. فأنا قلنا طبيعيا إنه يكون هنا 5 مربعات صغيرة أقصى حد. فالآن لما أجي أعد هذا المريض ألاقي 1 2 3 4 5 6 7 8 مربعات صغيرة من بداية البي ويف لبداية الكيو ويف. ف 8 ضرب 0.04 is 0.36. نورمالي طبيعيا المفروض تكون أقصى حد 20% من الثانية. بما أنها أطول من 20% من الثانية، فهذا الريذم أسميه ساينس ريذم، لكن في first degree AV block. it is a first degree AV block، فنسميه يعني نظم طبيعي لكن يحتوي على الدرجة الأولى من الانسداد في العقدة الأذينية. أوكي، this is the first degree of the AV block. طيب في second degree AV block، بالسكند ديجري ايفي بلوك، اوكي، انا عندي النوع الاول اللي هو فيرست سكند ديجري تايب 1، يكون عندي فتره انتقال التيار الكهربائي من الاذين للبطين اللي هي البي ار انترفال، تبدا بفتره قصيره شورت، بعدين تصير اطول. فاذا عدينا هنا من هنا لهنا 1 2 3 4 ضرب 0.04 هي 0.16، هذا نورمال. بس لما نيجي هنا حتلاقيها 1 2 3 4 5 7 7 تايم 0.04 0.28، فهنا 0.16 هنا 0.28 وهنا جايه 5 10 12 فهنا 0.48. فهنا في تباطؤ واضح لحد نوصل انه البي ويف كوندكتد في الاي في نود، يعني صار في شعلة كهربائية في الأذين لكنها تم حجزها في العقدة البطينية، فالاي في نود بلوكتد، فهنا لم تستطيع المرور. هذا اسمه انسداد او بلوك. اوكي، فانا عندي بي ويف لكن ما عندي كيو ار اس. انا عندي يعني اتريال كوندكشن بس ما عندي فنتريكولار كوندكشن، وهذه الظاهرة متكررة، يعني تبدأ بهذا الشكل لكن تنتهي دائما تكرر نفس الظاهرة. يعني حتى لو أخذتي ECG ستريب طوله 2 متر، اوكي، you will see that it is a cyclic، يعني عملية تعيد نفس الدائرة، اوكي، تكرر نفس المبدأ. طبعا يعالج هذا بالاتروبين والابنفرين، اوكي، ونحتاج لجهاز اللي هو منظم القلب. اوكي، نحتاج لمنظم القلب. طبعا الانسداد من الدرجة الثانية منه النوع الأول اللي هو هذا، ومنه النوع الثاني. النوع الثاني اللي يكون اللي هو تايب 2. تايب 2 درجة أسوأ من التايب 1. اوكي، الدرجة هذه أسوأ من التايب 1. فيكون عندك كل بي ويف وراها كيو ار اس، لكن في بعض البي ويفز ما فيهم كيو ار اس، تحتاج برضو لاتروبين وبيس ميكر هنا. اوكي، نفس القضية. طيب انا عندي الدرجة اللي نسميها 2 to 1، يعني يكون في عندي واحدة من البي ويفز تمر والثانية ما تمر، واحدة تمر واحدة ما تمر، يعني one is blocked وthe second one is conducted. هذا نسميه احنا درجة ثانية من النوع اللي 2 ل1. اوكي، فتلاقي نبض الاتريا ضعف، يعني عندك عدد البي ويف يكون ضعف عدد الكيو ار اس بالضبط. اوكي، فتيجي الفنتريكولار ريت 1 2 3 4 5 والاتريال ريت 100، هذا نسميه من النوع 2 ل1. اوكي، نسميه 2 إلى 1. طبعا هذا الانسداد مع انخفاض في درجة اللي هو نبض القلب يؤدي إلى نقص الكاردياك output. This bradycardia will lead to decrease cardiac output. فلما يصير في عندي decreasing cardiac output, what's gonna happen? The patient blood pressure is gonna be low. فهنا ضغط المريض ينزل لأنه عمل القلب ينخفض بنسبة 50%. اوكي، فنحتاج انه احنا نزيد من سرعة القلب عشان نعوض في قضية ضغط الدم. فالحل انه انا ازيد عدد نبضات القلب عن طريق الاتروبين او الابنفرين انفيوجن، او اني استخدم البيس ميكر. اوكي، طيب الانسداد الكامل اللي هو الكومبليت ايفي بلوك يكون عندي الايفي نود تشتغل ما تشتغل نهائيا، يعني الاتريا النبض الاذيني موجود والنبض البطيني موجود، لكن كل واحد منهم في بيسر مختلف. اوكي، يعني هنا الفنتريكل is paced alone. اوكي، اما من الاي نود او الجنكشن، والاس اي نود تشتغل لوحدها. فهتلاقي الاتريال ريت ريجولار، هيو البي ويفز 1 2 3 4 وات ايفر، لكن والكيوريسز برضه ريجولار. اوكي، والاتري والكيوريسز برضه ريجولار ار تو ار، لكن ما في علاقه ما بين البي والكيوريسز. هنا البي ويف جاي ورا التي ويف، هنا جايه ضمن الكيوريس. ليه؟ لانه كل واحد فيهم يشتغل مفصول عن الآخر تماما. أوكي، مفصول عن الآخر تماما. الحل هنا في هذا الحالة إن نحط المريض على البيس ميكر. أوكي، الحل إن نحط المريض على البيس ميكر. طبعا إحنا عندنا جهاز الديفبريليتر، البادز الموجودين عليها can be used, the defibrillator pads can be used as a pacemaker. يعني almost all defibrillators they have the chance for transcutaneous pacemaker. Okay, this is what is happening in the AV block. Okay, this is what is happening in the AV blocks. Okay, طيب الآن نتكلم عن البيس ميكرز. اوكي، كل الAV، كل الكاردياك، all the AV blocks might require a transvenous pacemaker. What do you mean by a transvenous pacemaker? We insert a central catheter. Okay, it's like a sheath or a cannula, a big cannula in the subclavian vein. اوكي، فاحنا نركب قسطره قصيره وحجمها شوي كبير في الشريان اللي يوصل للأذين، في الوريد، عفوا مو الشريان، في الوريد اللي يوصل للأذين. So we insert a central venous sheath، يسموه احنا كوردس. اوكي، او introducer sheath او introducer cannula. هذه عشان نمرر منها اللي هو أسلاك البيس ميكرز. فوي insert the pacemaker wires، هذا بالنسبة للانترافينوس. اوكي، and we can pace the ventricle and we can pace the atria and we can pace both of them. Okay, we can pace both of them. Okay, so for the transvenous طبعا بعض المرضى اللي ما بعد جراحة القلب ممكن يحطوا لهم أسلاك مشبوكة بعضلة القلب نفسها، احنا نسميها epicardial wires، بس هذه فقط نشوفها ما بعد جراحة القلب الإبيكارديال. بس الانترافينوس بيسر ممكن تشوفه مع أي مريض في الطوارئ أو العناية المركزة. أوكي، أو السي سي يو، ممكن إنه هذا المريض يتركب له اللي هي يسموها بطارية خارجية. أوكي، سميها بطارية خارجية أو منظم لنبض القلب. أوكي، خارجي، اسمه pulse generator، اسمه pulse generator، مولد نبض كهربائي. أوكي، مولد نبض كهربائي. الآن هذه الأسلاك إيش تعمل؟ تعمل على عملية المحافظة على نبض القلب. أوكي، نحافظ على نبض القلب بهذه العملية. طبعا what are the uses for the pacemaker? The pacemaker can use to support patient with severe bradycardia and or heart blocks lead to hemodynamic compromisation. Okay, طيب هلا when we say heart block or bradycardia may be due to surgery. Okay, myocardial infarct أو electrolyte in disturbance أو toxicities، يعني زي الديجيتاليس توكسيسيتي. ترى بعض الأدوية اللي تعطى لتخفيض نبض القلب أوكي أو لمعالجة بعض الاضطرابات بنبض القلب قد تؤدي إلى انسداد كهربائي. Some of the medications that are used to treat tachycardia or arrhythmias can cause heart block. مثال عليهم الديجيتاليس توكسيسيتي. فأنت لما تعطي المريض الديجوكسين، ممكن الديجوكسين إذا وصل لمستوى سام في الجسم إنه يؤدي إلى تباطؤ شديد جدا وانسداد بالتوصيل الكهربائي. أوكي، طيب فهذه فكرة البيس ميكر. فأنا عندي I can pace الفنتريكل وكان pace الأتريا. طيب إذا أنا I am pacing الفنتريكل نسميه VVI. أوكي، ventricular pacer. وإذا أنا pacing الأتريا نسميها AAI، يعني pacing والاتريا، اتريا البيسر. واذا انا اي ام بيسنج الاتريا والفنتركل مع بعض نسميه ديوال بيسر، نطلق عليه دي. اوكي، يعني ديوال بيسنج، ديوال انهبيشن اند ديوال سينسينج. فهذه هي فكره البيس ميكر اللي هو الانترافينوس بيس ميكر. طبعا تحتاج لتدريب معين على استخدام الجهاز، وغالبا المريض يكون تحت المراقبة في العناية المركزة. أوكي، بس الفكرة إنه أنا البيس ميكر في أون وفي كيبل موصول عشان أقدر أعمل تحفيز كهربائي لعضلة القلب اللي هي البيسنج. تحتاج إنك تضبط الريت. اوكي، تحتاج انك تضبط الريت. You need to control the rate و you need to control the output. الاوتبوت اللي هي كمية الكهرباء اللي نحتاجها علشان نقدر نحفز عضلة القلب. So the output is the amount of energy that is required to stimulate the heart. هذا نسميها الاوتبوت. بعدين احتاج للسنسيتيفيتي، لانه الجهاز لازم يتعرف على اذا كان المريض عنده نبض او لا. ليش؟ لانه انا عندي بالنسبه للبيس ميكر، for the pacemaker I am using a demand mode. ايش يعني demand؟ if the patient is brady and his heart rate is 30 وmy desired heart rate is 70, the pacemaker will give 40 in addition to the 30 that is done by patient. اوكي، إذا كان المريض نبضه 30 وأحتاج إنه نبضه يكون 70، فالبيس ميكر راح يعطي المريض 40 نبضة بالتعاون والتزامن مع النبض المريض الأساسي. يعني المريض هو جالس يعمل 30، فالبيس ميكر حيعطيه 40. Okay, so the patient is having intrinsic rate of 30. The pacemaker will give him 40 beats per minute in order to make the total rate of 70. So this is how the pacemaker is working in bradycardia. So it's a cable or with the wires connected to other pulse generator that will give the patient rate in order to maintain adequate rate. Okay, to maintain adequate rate. But this is exactly what we are doing when we are pacing the patient. We are conducting electricity. إنه لازم عضلة القلب تحتاج لتحفيز كهربائي علشان يصير نبض. فبما انه عندي النورمال الاون ريت، يعني نبض المريض الاساسي منخفض لانه براديكارديا او عنده هارت بلوك اصلا، فاحتاج لمنظم كهربائي خارجي. اوكي، في البدايه، بعدين ينزل على المريض بطاريه داخليه اذا احتجنا. Later, if the patient needs, then there will be an implanted pacemaker. Okay, there will be an implanted pacemaker. Okay, طيب هذا شكل البيس ميكر. هنا هو في حالة الشغل. اوكي، عندك اون الهارت ريت تكون مثلا 80 والسنسيتيفيتي مثلا 10، وهذا المود هنا في اي. يعني في اي انا I am pacing الفنتريكل. اوكي، I am pacing الفنتريكل. احتمال يكون هذا المريض عنده complete heart block. اوكي، عنده complete heart block. واذا شفنا هنا، اوكي، إذا شفنا هنا مثلا هذا failure to pace يعني البيس ميكر is not working. فزي ما تشوفوا هنا المريض does not have a heart rate. لكن هنا this is the normal pacing where every pacemaker spike، هذا شايفين السبايك اللي هنا، هذه هي الإشارة الكهربائية إنه البيس ميكر يشتغل، فنحتاج دائما أوكي للعمل مع هذول المرضى. إذا ممكن تتحدث باللغة العربية حعيدها، هذه النقطة راح أعيدها باللغة العربية. أوكي أبشر ولا يهمك. طيب نرجع من أول. إحنا قلنا أي مريض عنده انخفاض بنظم القلب يحتاج إلى منظم للقلب. مريض عنده انخفاض بعدد نبضات القلب، أوكي، عنده انخفاض بعدد نبضات القلب، فهذا الشخص يحتاج إلى بطارية خارجية، يعني يحتاج لجهاز يولد نبض. فهذا الجهاز اسمه جهاز منظم عمل القلب اللي هو البيس ميكر. طبعا هذا عبارة عن جهاز خارجي تطلع عليه كذا شكله زي الجوال، أوكي. ففي أنبوب يتدخل عن طريق الوريد الموجود بالصدر. طبعا ندخل هذا الجهاز، ندخل من هذا القسطرة سلك كهربائي إلى داخل عضلة القلب، يوضع داخل البطين، أوكي. وهنا في قطب كهربائي، غالبا يكون في منه قطبين كهربائيات، قطب سالب وقطب موجب، ومشبوك على كيبل هنا في الجهاز، ويتثبت ببالون. شايفين هذا البالون اللي هنا؟ نعبي هذا البالون صلاين على أساس يجلس هذا الكيبل، أوكي، أو السلك الكهربائي يجلس داخل عضلة القلب. إيش وظيفة هذا؟ له 3 وظائف. الوظيفة الأولى إنه هو يستطيع التعرف على نبض المريض الداخلي، وهذه إحنا نسميها السنسيتيفيتي، اللي هي حساسية الجهاز لنبض المريض، أوكي. هذا 1. 2، الجهاز لما تحطه على 80، أوكي، أي نشاط كهربائي للمريض يخصمه من هذه 80. يعني إذا المريض قادر على أنه يعطيك 30 ريت بالدقيقة، فالجهاز راح يعوض المريض ب50. لما يصير المريض يعطي 40، الجهاز يعطي 40. إذا صار المريض يعطي 80، الجهاز راح يتوقف عن العمل تماما بشكل آلي، وصار المريض خلاص ما يحتاج هذا الجهاز، أوكي. طبعا يتم تركيب هذا الجهاز إما بقسم القسطرة، أو ممكن إنه يتركب بقسم العناية المركزة أو الطوارئ، أوكي، أو الطوارئ. فكل مريض عنده انخفاض بعدد نبضات القلب بشكل مؤقت أو دائم يحتاج إنه يتركب هذا الجهاز، أوكي، بيحتاج إنه يتركب هذا الجهاز. فالجهاز زي ما قلنا بيتعرف على نشاط المريض الداخلي، يعني المريض عنده 30 نبضة في الدقيقة، ويكمل له النبضات الناقصة بحيث إنه يعمل عملية تنظيم للوقت، أوكي، لوقت النبضة بين المريض والمريض، أوكي. نحتاج للإشراف على هذا الجهاز إنه إحنا نبدل البطاريات بشكل يومي كل 24 ساعة، أوكي. وتحتاج لتدريب خاص على هذا الجهاز. إذا وظيفة هذا الجهاز إنه هو يعطي الشرارة الكهربائية الداخلية، لأنه نظام الجهاز المنظم لعضلة القلب الطبيعي غير شغال. فإحنا قلنا إيش متى نحتاج هذا الجهاز؟ إذا عندي انخفاض بدرجة بالنبض، أو إذا كان المريض عنده هارت بلوك، عنده انسداد في العقدة الأذينية البطينية، بحيث أنه عدد نبضات القلب لا يكفي لتزويد الجسم بالدم، أوكي، لتزويد الجسم بالدم. فهذا هو منظم القلب. طبعا هذا خارجي. إذا كانت مشكلة المريض دائمة، فنحتاج أن نزرع نفس الجهاز لكن بحجم أصغر داخل جسم الإنسان، وغالبا هذه متعارف عليها على أنها البطارية المنظمة لعضل القلب، أوكي. طبعا إحنا لما نركب الجهاز على المريض لازم يكون عنده القسطرة القلبية موجودة، أوكي، والسلك اللي يوصل التيار الكهربائي مشبوك على الجهاز، وإحنا نحط هنا عدد النبضات ومستوى حساسية الجهاز للمريض، ووين الجزء من القلب اللي إحنا جالسين نعمل له تحفيز. ممكن نحفز الأتريوم، حتلاقيها هنا A، وممكن نحفز الفنتريكل، حتلاقيها هنا V، أو ممكن نحفز 2 وحتلاقيها هنا ديول، أوكي. دي يعني ديول both chambers. الأذين والبطين اللي يتم تحفيزهم من أجل اللي هو التنظيم الكهربائي. أوكي، من أجل التنظيم الكهربائي. طبعا نحتاج أن نراقب، لأنه إذا هذا الجهاز فشل في العمل حتلاقي عندك على التخطيط ظاهر انه ما في نبض. هنا شايفين هنا في نبض، لكن هنا هذا سميناه failure to pace. فكل مريض على هذا الجهاز يحتاج انه يكون في العناية المركزة، اما العناية المركزة العادية او العناية المركزة القلبية، ويحتاج الى مراقبة دائمة. اوكي، يحتاج الى مراقبة دائمة. اوكي، فهذه بالنسبة للAV بلوك وهاو دو وي تريت ات. اوكي، هذه بالنسبه للاي بلوك وهاو دو وي تريت ات. طبعا ممكن هذا الجهاز يجلس مع المريض اشهر، شهر، شهرين، اذا كان الطبيب يعتقد انه هذا الجهاز، انه المريض بعد فتره راح يرجع للنبض الطبيعي، او في علامات انه المريض عم يتحسن. إذا ما تحسن المريض إحنا ممكن نستبدل هذه بالبطارية الداخلية. أوكي، في حدا عنده أي سؤال بالعربي؟ Does anyone have any question in English or Arabic about the pacemaker? Okay, we introduce this as part of the therapy. We talk about pacing, and I wanted to show you how the pacing is happening. احنا دائما نتكلم انه احنا المريض اللي عنده تباطؤ يحتاج لمنظم قلب، فانا حبيت اجيب هذه الجزئية في المحاضرة حتى نتعرف على الأجهزة المنظمة لعمل القلب. Okay, if you have any question about it, please feel free to ask. If you have any question about pacemaker or about AV block, you can ask me. إذا عندك أي سؤال على أي شيء في المحاضرة من الصباح لليوم، إذا عندكم أي سؤال عن أي شيء فمعنا وقت نسأل. أوكي، طيب علي يسأل what is the difference between atrial pacer and ventricular pacer. ممتاز السؤال. إيش الفرق بين تنظيم الأذين وتنظيم البطين؟ هلا الventricular pacer we use it in general for patients who have bradycardia and their cardiac function is normal. Okay, their cardiac function is normal. طيب إحنا إيش يعني cardiac function is normal؟ The cardiac function is diastolic and systolic. Diastolic means the heart can fill. Okay. طيب حجاوب على why pacemaker is not allowed in CT or MRI. In CT scan there is no problem. In MRI there is a problem. Okay. بس خلينا أجاوب على سؤال علي أول. Let us answer the first question. What is the difference between atrial pacer and ventricular pacer? هلا if the patient has good diastolic function, means the filling of the ventricle is good, ventricular pacemaker is enough because I need the contractility. But if patient has abnormal ventricular function, okay, abnormal ventricular function and diastolic failure, okay, diastolic failure is not there, or patient has abnormal atrial function, يعني like a chronic acute atrial fibrillation that is not responding to therapy, I might pace the atria. Okay, I might pace the atria in order to create a normal atrial pacing. Okay, in order to get a normal atrial pacing. If the patient has abnormal atrial pacing with the heart is weak, I need to pace atria and ventricle. Okay, فاحتاج انه انا اعمل pacing للاتريا والventricle. Majority of patients, يعني 90% of patients, they require only ventricular pacer. They require only ventricular pacer لأنه إحنا نعتمد we depend on the ventricle for the cardiac output. بس إذا كان عندي أنا weak ventricle و I cannot fill it, I need the atria also to participate in ventricle filling. I will pace both atria and ventricle. Atria and ventricle. Okay? In the third degree AV block, usually we pace the ventricles only. Okay? This is for the first question. What is the difference between atria and ventricular pacer? طيب, there is one difference also. The atrial pacer will cause P wave, or the ventricular pacer will give me a QRS. Okay? And if you look here, the spike is before the QRS. So this is ventricular pacer. طيب, لو كان atrial pacer, the spike will be before the atria. طيب, why pacemakers are not allowed in CT scan or MRI? In CT scan, I don't have a problem. Okay? But in MRI, the pacemaker is not compatible with MRI. So I need to get a pacemaker that is compatible with MRI. لأنه ال MRI فيها magnet. There is a magnet in the MRI. Okay? So you need to make sure that the pacemaker is compatible with MRI. And majority of pacemakers are not compatible with MRI because of the magnet. Remember, the magnet field will interfere with the programming. ال MRI فيها مغناطيس يشطب البرمجة حقت الأجهزة. Okay? So the magnet field in the MRI will interfere and might disable the pacemaker. That's why pacemakers are not allowed in MRI, but they are allowed in CT scan. CT scan, there's no problem. لأنه CT scan عبارة عن أشعة عادية. Okay? لكن ال MRI فيها مجال مغناطيسي فما ينفع. X-ray is okay, no problem. I have patient here in the ICU. They have pacemakers. Every day we do X-ray. The X-ray does not interfere. What interferes is the magnet. المغناطيس اللي في ال MRI يعطل عمل البيسميكر. Okay? The MRI magnet field will disable the function of the pacemaker. That's why I don't have a problem with normal X-ray. I don't have a problem with CT scan. I have a problem only with MRI. Okay? Clear? Even implanted pacemakers, majority of them are not compatible with MRI. لأنه ال MRI يشطب البرمجة حق الجهاز. It will alter the programs of the machine. It will disable it. Okay? حتى المرضى اللي عندهم pacemaker في المطار، اوكي، ما يمر من الديتكتورز لأنه it might interfere with the pacemaker لأنه فيهم magnet. Any question more? If there is no more questions, we are done, okay? إذا ما في أي سؤال إحنا نكون خلصنا اليوم. If you don't have any questions, we are done. This is the last part of the AV blocks, okay? You are welcome. Thank you very much. طيب, good question يا علي. How adenosine affect SVT? Thank you. والله you are asking very good questions. Adenosine is an AV blocker. الأدينوسين يوقف عمل ال AV node. هلا when you give adenosine, you stop the conduction totally. So what is going to happen when you stop the conduction totally? Okay, the electric charge of the AV node will go to 0, and this is going to stimulate the SA node to function again. So that's why the SA node, when you stop the AV node completely, you are stopping all the abnormal pacing in the heart. So the AV node will take the lead again. Okay? طيب. ممتاز. في حال حدوث توقف عضلة القلب لمريض موجود المنظم الداخلي. اوكي؟ طيب الآن يا دلال السؤال واضح. مريض عنده بيس ميكر، الأصل إنه البيس ميكر ما يتوقف. اوكي؟ It's gonna keep working. there is no reason for the pacemaker to stop. بس إذا المريض دخل ب VF مثلا، اوكي؟ احنا we will do CPR عادي. We will do defibrillation عادي. اوكي؟ ليه؟ Why? Because some pacemakers are only pacemakers. Some pacemakers are pacemakers and defibrillators. If I know that this patient has only a pacemaker without a defibrillator, I will do normal CPR and I will do defibrillation regardless of the presence of the pacemaker. Okay? واضح؟ عادي أعمل CPR وأعمل defibrillation بشكل عادي. واصلا اذا كان عندي المريض عنده بيس ميكر داخلي وهذا البيس ميكر توقف عن العمل، استعيض عنه ببيس ميكر خارجي اللي هو عن طريق الديفبريليتر. ولو احتاج المريض CPR وديفبريليشن I will do normal as like any patient as if there is no pacemaker. طيب setting of transcutaneous pacemaker in energy. اوكي نادية, setting of transcutaneous pacemaker in emergency situations. Very good. This is a very good question. هلا انت you have the pacemaker pads صح؟ اللي هم defibrillator pads. واحدة محطوطة على الابيكس والثانية محطوطة على الستيرنم. You will turn وتتأكد انه الاي سي جي electrodes موجودين وعندك اي سي جي on. اوكي؟ الاي سي جي is on. الاي سي جي الكيو ار اس has to be longer than 1. فتحط الاي سي جي على 1. هذا السايز اوف ذا كيو ار اس فور ذا بيس ميكر تو ريكوجنايز ات. بعدين يو سويتش اون ذا بيس ميكر، تحط البيس ميكر اون. بعدين يو put the rate 70 ويو go to the output. You increase the output until you have a spike followed by QRS. اذا لسات انت على السكرين حتحصل عندك هذه الصورة. شايفة هذه الصورة a spike followed by a QRS. هذا إيش نسميه؟ هذا نسميه ventricular pacing followed by a QRS. أوكي هيا it's a wide QRS. أي واضحة جدا. أوكي هيا a wide QRS because the beat is initiated from the ventricle. This is exactly what you should see. هذا إيش نسميه؟ نسميه إحنا electric كابتشر. فنتأكد انه نبض المريض قوي وضغط المريض كويس. فسهل جدا بالنسبة للترانسكوتينيوس بيسر، سهل جدا. تحط البيس ميكر بادز ويو تيرن اون البيسر ويو set the rate 70 او 80 ويو go up with the output 10 20 30 40 50 up to the maximum in order to make sure that you have a QRS. اوكي والQRS نتأكد انه رجع المريض الكوندكشن اوف ذا هارت از جود عن طريق انه يرجع الضغط. طيب اذا صار عندي انا هنا سبايك فولد باي كيو ار اس بس ما عندي النبض المريض قوي، ازيد الاوتبوت. يعني اذا كان على 40 اخليه على 10، ازيده 10 20 30 40 مثلا 60 70 80 حتى احصل جود pulses. اوكي واضح؟ فلانه الديفبريليتر بادز الموجودين عندنا اوكي اللي كان عند الديفبريليشن البادز يستخدموا للديفبريليشن ويستخدموا للبيسنج بنفس الوقت. طيب هذا الجواب لنادية. علي يسأل you said we can use atropine in the approach you mentioned but how we can give atropine in bradyarrhythms and we can give also in tachycardia. لا, we don't give atropine in tachycardia. And I did not teach tachycardia today. I talked about only blocks and bradycardia. In junctional tachycardia, we don't give atropine. In junctional tachycardia, the best treatment is pacing. Okay? DC shock for what? DC shock is only for ventricular tachycardia without pulse and ventricular fibrillation. هذا بالنسبة لسؤال دلال. DC shock فقط في الVF والpulseless VTAC. الاتروبين فقط في البراديكارديا. There is no atropine in tachycardia. في التاكيكارديا we can give calcium channel blockers, we can give beta blockers, we can give antiarrhythmia. In junctional tachycardia we don't use cardioversion, we use only pacing. لأن ما في SA node. Okay, ما في, we don't have an SA node in junctional tachycardia. That's why cardioversion is contraindicated in junctional tachycardias at all. If you want to give electric therapy, you should use pacing. This is exclusively in junctional tachycardia. No cardioversion. لأنه if you cardiovert, you will stop the heart. لأنه أصلاً ال SA node is not functioning. Your pacer is the junction. So you don't have an SA node to bring it back. واضح؟ في الجنكشنال تاكيكارديا لا تعملوا كارديوفيرجن، اعملوا بيسنج. لأنه أصلاً الاس اي نود مو شغالة حتى أرجعها. فذاتس واي our natural pacer is the junctional. فنساعد المريض بإبنفرين أو نساعد المريض ببيسر إذا كان الكاردياك أوتبوت لو. أوكي؟ واضح؟ اسأل ولا حرج. Ask all your questions, please. We are here to make things clear for you. And I like your questions. All your questions are important, are very smart questions. Anything not clear since morning, please ask. We will answer you. أي شيء مو واضح تحتاج تسأل عنه، اسأل. اسأل ولا حرج زي ما يقولوا. أوكي؟ افعل ولا حرج. When is synchronized and when is the... أوكي ممتاز. علي، السynchronized cardioversion استثني الساينس تاكيكارديا والجنكشنال تاكيكارديا. أوكي؟ هذول ممنوع فيهم الكارديوفيرجن. عندك اتريال تاكيكارديا بكل انواعها سواء اتريال او SVT او الفنتريكولار تاكيكارديا with pulse. اوكي؟ يعني اتريال فيبريليشن، اتريال فلتر، SVT. اوكي؟ وفنتريكولار تاكيكارديا with pulse والمريض يكون unstable blood pressure, you can use synchronized cardioversion. Defibrillation is exclusively for VF, ventricular fibrillation, and pulseless VTAC. واضح؟ أنا عندي فقط 2 defibrillating rhythms, VF or pulseless VTAC. Synchronized SVT, atrial fibrillation, atrial flutter, atrial tachycardia, ventricular tachycardia with pulse, but the blood pressure is unstable أو المريض is not responding to medication. هذول السynchronized cardioversion. السynchronized cardioversion ممنوع في الجنكشنال tachycardia والساينس tachycardia. طبعا عندك exclusively التورسادس D point unstable has to be defibrillated, بس تحتاج لكارديولوجيست to approve it for you لأنه مو الكل يوافق على الديفبريليشن التورساتس دي بوينت اللي هي البوليمورفيك في تاك، هذه يكون فيها بلس والبيشنت انستيبل، تحتاج ديفبريليشن، بس لازم يكون في كارديولوجيست موجود او انتنسيفست to approve it. بس إذا كنت ACLS certified you can do synchronized cardioversion or you can do defibrillation but not synchronized cardioversion. Synchronized cardioversion you require to have a doctor with you. ولازم الدكتور يكون ACLS certified. واضح؟ Good. Thank you. ال AHA ال ACLS تعرف تدخل على acls.net. عايشة عمر عايشة، ال acls.net فيها كل هذه الأشياء، كل السيناريوز موجودين هناك. ادخل على شيء اسمه acls.net. اوكي كده اكتب لك اياها acls.net. اوكي كل هذه المعلومات موجودة هنا. جيد. والله ما شاء الله عليكم very interactive group. الله يعافيك حياك الله. Okay, we are done. If anyone want to leave, you are free to leave, okay? شكرا يا عائشة وإياك إن شاء الله. جزاكم الله خيرا جميعا. Thank you very much to everybody. Appreciate. يعطيكم العافية جميعا. Thank you very much. يلا إن شاء الله we'll meet you next lectures, okay?
Thank you.